We are live.
Good evening, everybody. This is Dr. Deepak Dave on behalf of our local organizing committee of GOSICON 2021, along with my colleague Dr. Bharat Dave and my team members. We all welcome you here for this wonderful academic program, GOSICON 2021. I request Dr. AMARNATH to say a welcome note, and then we straight away go to the academic program. We are very fortunate to have a galaxy of eminent faculties from India and overseas. And I'm sure for 3 days, this conference is going to be very useful and fruitful to all of us. I request Dr. AMARNATH to say a few words.
Thank you. And thank you, Team GOSICON 2021, Virtual GOSICON. It's a pleasure to have you folks back on the virtual platform. I know it would have been really nice to have a physical one, but unfortunately, thanks to Corona and other things, we are still virtual and we are well connected. Now, coming to GOSI and GOSICON, GOSI, short form for GOSI, is Geriatric Orthopaedic Society of India, was formed in 2013 in the view of keeping geriatric orthopedic patients that we all are having in our practice in a massive way. We need to focus, we need to have a focus group, we need to have a thought process so that we as a professional body coming together to make sure that the kind of treatment what the patients has been given is going to be very, very important, and we will make sure that it is world class. Hence, on that background, this was started, and I'm thankfully, it is really, really good. We are a national body, nearing 1,000 plus members now, and going stronger. This year is 9th year, and next year happens to be a 10th anniversary, and it's going to be big. I encourage each one of you to attend GOSI meetings today, tomorrow, and day after. 3 days of event, which is going to be very, very different from the usual didactic lectures. It's going to be case-based studies, and each one of us will be facing or would have faced or probably in the future will face these kind of challenges. And what the experts have done, if that fracture, if I were to see, if this condition, if I were to see, what could I do in my own setup? What have they done? What differently they have done? What different that I can do? So big knowledge sharing, knowledge absorbing, and putting into action for a better care and for a better India. Thank you. Thank you, Team GOSICON 2021. We announce it's open now.
Thank you, Dr. AMARNATH. We straight away go to the first academic session. Fortunate to have Dr. Mahesh Kulkarni, very eminent arthroplasty surgeon from Pune. He is going to moderate the session on the hip arthritis, and we have a galaxy of eminent faculties, as I told you. Dr. Anil Omen from Vellore, Dr. Karthik Patel from Ahmedabad, Dr. L. Bharat from Chennai, Dr. Subhranshu Mohanty, the Indian Arthroplasty Association President from Mumbai, Abhay Helans from Jodhpur, he's worked with AIMS there, and our own Dr. Vivek Neginal, is early morning for him in USA. From the East Coast, he has also joined. So I request Dr. Mahesh Kulkarni to share the screen, start the ball rolling. You are the opening batsman, and we are very grateful to you and the panelists here to start the hip session. Thank you very much.
Yeah, thank you very much, Dave and the GOSICON team for allowing us to present this panel discussion. So I welcome all the panelists, and I just want to take a brief moment to introduce the panelists as well. We have fortunate to have Dr. Neginal, who is a senior orthopedic surgeon in the United States, currently director of the Joint Replacement Center at St. Mary's, Huntington, USA. Fellowship trained with Dr. Ranawat at Lenoxville Hospital. We have Dr. Patel and Dr. Subhranshu Mohanty, my dear friend Abhay Helans from Jodhpur. Let me start by saying that I'm going to just show a few cases So these are going to be primary hip replacement cases that I want to highlight from the view of the geriatric problems that we commonly see. So basically, we are going to talk about a few of failed femoral fracture fixations, some post-acetabular fracture scenarios, which are also very common. Ankylosed hips are uncommon in elderly patients, so we will not spend too much time on it, and dysplastic hip. So we will probably try and sort out them according to the algorithm that we mentioned, the pre-op plan, the surgical approach that the surgeon would decide on, the choice for treatment on the acetabular side and on the femoral side. As we all know that if you fail to plan, you are going to plan to fail. So we will discuss amongst the eminent faculty to anticipate problems, to talk about organizing implants, availability of bone grafts as well. So let's start with the first case. So I might start requesting Dr. Ajay to talk about, this is a lady in her 70s, presented to me with this above X-ray, had the fixation of this femur fracture done about a year ago, now has immense pain in the right hip joint and disabled. So what are your primary thoughts, Dr. Ajay?
So, hi Mahesh, thank you, and good evening, everyone. So my first thought is that why should a primary well-done DHS cause an avascular necrosis of a hip? I would basically be thinking, has it cut out laterally? So I would like to see the lateral views as well. And sometimes we do get avascular necrosis of the femur. So the X-ray doesn't show as if it's going to have a major problem on the acetabular side or on the femur side. But just to be sure, I would like to see, get lateral X-rays and see if something has happened or the lag screw is cut out posteriorly, which it doesn't seem so. So otherwise, it would be a straightforward uncemented primary hip in my hands, removal of the DHS and an uncemented acetabular cup component and a femoral component in my hands.
Unfortunately, I don't have the lateral X-ray. This is what we have got. Preoperative investigations have shown the ESR of around 30, CRP of around 14. There is no history of infection in the postoperative period. So I would like to ask Dr. Patel about his future plans for this hip.
Okay. So looking at the X-ray, there seems to be erosion of the acetabulum. I would like to investigate more with some imaging like Judet views or CT scan, because sometimes what happens that this screw might cut through the head part or neck part and might erode the posterior wall or posterior column. And that's sometimes an on-table surprise that your posterior wall or posterior column is gone. And that might make the acetabulum reconstruction more difficult. So I would like to investigate more with the more imaging like Judet views and the CT scan for the acetabulum part especially. And straightforward, then if it's okay, then it's straightforward uncemented, we can plan for the uncemented total hip replacement.
Yeah, what do you think, Anil? Sorry, I didn't get a chance to introduce you. So Anil is a dear friend from CMC. So I'm going to take his opinion. Would you really go for a CT scan in this case, or?
Not really, Mahesh. I don't think so. If you have a lateral view and you're fairly certain, I do not anticipate significant problems on the acetabular side. However, I would be worried about one thing. I would be worried about a template, because I'd like to know whether it's leaning towards a high offset, especially on the femoral side. And that's what I would be more keen on re-establishing yesterday, especially in the geriatric age. So I would look at probably how the offset on the other side looks like, and I would be ready with a high offset. Having said that, you said the ESR and CRP on the elevated side, I would go in prepared for a staged. However, all well, if necessary, go in for a frozen at all. But you said there's no history suggestive of any discharge, nothing else, then probably straightforward. Send off samples, and if anything grows back, we can continue on antibiotics from then on, because you don't want to undertake a 70-year-old for 2 procedures. And only thing I would say is basically, even though the cortices look fairly okay, acetabulum, I would probably go for an uncemented shell. If the hold is not good, then I would keep cemented backup. And the femoral side, probably I wouldn't want to hammer an uncemented, keep a cemented ready, but only thing I would be worried and doubly check is the high offset step.
Yeah. Okay, perfect. Dr. Bharath, would you like to add anything about the choice of implants? We've decided that we're going to go for hip replacement here. We are considering that there might be a slight possibility of infection, but we will take a decision on table. So what would be your choice of implant, Dr. Bharath?
Yeah, I totally agree with it. And I also agree with Dr. Anil Thomas that a CT scan is not required in this particular case. And preferably a 2-stage would be a better option. In that case, uncemented both on the acetabular side and the femoral side would be a more better position. And the reason is we have a lot of sclerotic bone on the femoral side. The barrel canal is going to be much more sclerotic. In that situation, I doubt cemented would work well. So I would prefer a fully coated, for example, a coral stem in this particular case.
Is Dr. Vivek joined from the USA or Dr. Mohan?
Yes, I'm here.
Yes.
Can you hear me?
Good morning, Dr. Vivek.
Good morning, and good evening
What
to you
would
guys.
be your thought process from the other side, other continent?
I agree with most of that. One thing, I'm not too much worried about acetabular destruction because this doesn't look like it is cut out. So in the days of expensive medicine, you want to reduce the test as much as possible. My main worry here is going to be infection. And I don't think, I would not prefer to go in and find that out on the table because a lot of preparation goes into it. So if we have to think about that, it will be simple. Even before I even think about 2-stage procedure, I'm going to have aspiration done on the hip under CT guidance or just aspiration if you can in the office and send it for a culture. If it grows something, I would rather do it 2-stage then and take the implant out. Even though there's no infection, I always want to take the implant out, let it heal a little bit, and then give antibiotics and come back. That would be my choice. And then here, if I look back and say, when is the last, I love cementing. I'm a Chitranov fellow, so I love cementing, but I don't think I have done many cementing in past 600 to 800 cases, no matter what barrel canal or whatever. So they all do good. So I would go for a press fit on both sides. And only thing we have to make sure the short stem is not a good idea in here. There are a lot of short stem around the market now. I would pass at least 4 cortices across the distal screw.
Yeah, thank you very much. I completely agree with thinking about aspiration to rule out infection. Let's see what I did for this patient. We went for a cemented hip, the gold standard for elderly patients, a cheap alternative. What we need to do in such cases is obviously block the entry hole of the DHS, get a good cement mantle. This is a collarless, polished, tapered stem and a cemented cup. So I think they do extremely well. We know that the results of uncemented stems in elderly patients are fraught with periprosthetic fractures. That now has been proven. I do go sometimes with an uncemented hip as well, but I think this is a safe option. There was no infection, so we could get away with this. So let's quickly move on to the next one. So this is the second case, again, an elderly patient, fracture neck femur, subcapital fracture fixed with a couple of screws. And unfortunately here, there was risk of infection. So let's start with Dr. Patel. Dr. Patel, would you do a two-stage procedure here or consider a single-stage operation? There was history of infection here.
And so I would like to investigate with the hip aspiration.
Yeah.
And hip aspiration and investigate with the routine micro and the culture sensitivity along with the ESR CRP. And if marker suggestive of infection, then better to go with the two-stage procedure. But hip aspiration is mandatory.
Yeah.
Hip aspiration is mandatory.
Question to Abhay is, if you go for a two-stage procedure, you remove the screws and you take some samples, send the femoral head as well, because it was probably fibrous union. Do you use a spacer just as a continuity so that the patient can walk? Do you use a cement spacer for that the patient to be comfortable? Because they will go and have antibiotics for 6 weeks. And we just have to remember that we are trying to send a message for general orthopedic surgeons as well as some of the non-orthopedic surgeons. So maybe we can discuss a little bit less about the nitty-gritty of a hip replacement, but generally tell us about the treatment of infection in 2 stages.
Definitely, Mahesh, I would like to put in a spacer for the simple reason that it keeps the hip distracted, and it would to some extent maintain my horizontal vertical offsets to some extent. And it's an easier stage 2 procedure if I have a spacer in. Of course, if the patient has to wait for a longer period of time, sometimes the cement and the antibiotic impregnated spacer itself can start acting as a foreign body. But then with the neck femur, I would definitely like to put in a spacer. And there are multiple ways of doing it. And a very simple way, a technique of putting in a spacer is to cemented spacer with a reasonable length implant, a rush nail or a Steinman pin, a curved Steinman pin inside the femur, and debride the acetabulum and put in a spacer there so as to maintain the offsets to some extent, keep the soft tissue distracted. And the important bit is that I would like to make sure that I have done enough debridement into the femoral canal distally, so as not to have done just a superficial job around the peritrochanteric area, because distally in the shaft is where a lot of times we leave back the infection, and these patients tend to have persistent infection and complications post stage 2 conversion. So that's something that I would like to remember.
Okay, so thanks for that, Abhay. So Anil, do you just want to summarize in simple terms that if a failed fracture neck femur scenario comes in an elderly patient, what do we do? I mean, so that everybody can understand. We don't need to go into a discussion of different spacers or anything too complicated.
Sure. Failed fracture neck of femur, especially with an implant in situ, have a high index of suspicion for infection, get all the markers, preferably do a hip aspiration, again under sterile precautions, do it under image guidance so that you don't land up with having no fluid and no aspirate. Send for cultures, again, open up if there's everything else pointing towards infection, no problem about doing a stage procedure. Put in a spacer, easier to relocate or easier to identify the acetabulum when you go in for the second stage. Points already mentioned, keep it distracted, soft tissue contractures lesser, also allows, especially in the geriatric age group, a certain amount of mobilization. You can also have planning for the second stage, look at the acetabulum, look at the femur, eliminate all source of infection, come back and plan your fixation and execute your second stage without much ado, because your planning is much better. Your delineation is much better, and you're almost certain that you've ruled out infection.
Yeah, thank you very much. So I think we have seen 2 cases. This is the second stage we've done after 6 weeks of antibiotics. Again, we've gone for a hybrid hip, a cemented cup, uncemented cup, and a cemented stem. And that gives excellent results, and the patient mobilizes very fast. So I think the message from these 2 cases is fracture neck of
Mahesh, that's a
femur
high
or
offset stem. Sorry, that's a high offset stem, isn't it?
This is the standard CPCS.
CPCS, yeah. CPCS is offset is a little
Because the offset
usual.
increases as you go up the size
Yes,
of it.
yes, correct.
So the general message here is the fracture neck femur scenario is very common, especially in elderly patients. And they do come up with some failure rates, and you probably might get 10% failure of fixation of these proximal femoral fractures. So when they fail, we need to really start thinking about whether there is infection, there is no infection. So Dr. Vivek has explained very well his algorithm for doing an aspiration. The second thing is whether or not we should remove the implant, give them antibiotics. We need to really think about keeping them mobile. We don't want them to be in bed for too long a period. So we give them either put a spacer in, remove the implant, give intravenous antibiotics, but keep them walking, at least mobile to do their daily activities, and try and do the second stage to get them up and about as soon as possible. There's no point in putting an uncemented stem. You're not confident and keeping them further non-weight bearing for further 3 months. So I think that is what I would like to consider as a message from these failed fixations of the proximal femoral fractures. So
Welcome, Dr. Mohanty.
Dr. Mohanty, welcome as well. I haven't really seen him on the screen. So,
okay.
Sorry?
I am traveling, but okay.
Yeah, okay.
I'm
So be as long as you're not driving, that's okay for us. If you're driving, then I would be a bit worried.
No, I am listening and enjoying.
Okay. So the next case, I'm going to request Dr. Bharat to comment upon 65-year-old lady. So can you please tell me the thought process after looking at these X-rays?
It's a case of a bilateral severe Protrusio, grade 2 on the right side, grade 1 on the left side, type C door canal on the right side, or maybe on both sides. In this case, preferably a hybrid fixation, uncemented cup and the cemented stem with a mosseized bone graft to impact on the meating side. Try to be at least 0.5 to 1 centimeters lateralization of the cup. What was the diameter? Is that the SI joint is fused?
Yeah, so this is probably just a chronic arthritis presenting at a late age.
Is it
with
like that, or it is it look like an
inflammatory, the history of inflammatory arthritis.
Inflammatory arthritis, okay.
Yeah.
I couldn't see the SI joint.
So Dr. Vivek, I think Dr. Bharat has given him his opinion about how he will tackle this hip. Dr. Vivek, is he there online?
Yes, I'm here. I don't know, is my video feed coming through?
It is, yeah.
Okay, I can see. I try to keep things simple. I mean, can we make this into a fancy case? Yes. It'll be obviously needs a hip replacement, and the offset is very small, and I do all my hips anteriorly, and this is a nightmare going through anteriorly, but I still hang in there and do it anteriorly, and I've done that pretty successfully, even by anterior approach. We can use the, I don't know if the stem is still available in India. There's a small stem, Depume J&J Actus, it's called. The offset for that is smaller than the Korai regular stem. So I prefer that. And then we can go fancy by saying, let's get a deep profile cup, and they're expensive. So I can get away with just a regular hip. And if I feel the protrusio is too severe and there's a weakened medial wall, what I do is take the femoral head and shape into, or grind it, and then put the graft, and then reverse ream it. So you get a good bed of bone on the medial wall, and then do a regular hip. And I don't think we need a deep profile in here, because we are not in a situation where we need a higher offset. Then that would be useful to keep it as a standby. but this will pretty much regularly get away with that special stem and total hip replacement.
Okay.
And I don't think this should be.
Sorry.
Oh, I was just a word of caution. If you're any of the listeners, you are starting your practice in a hip arthroplasty, this should not be any of your first 30 or 40 cases.
Yeah. Good sound advice. Abhay, what do you think is the difficulty that you're going to anticipate before you even plan your implant?
Yeah, so the first
you start your approach, what is the difficulty that you are going to come across?
So the first couple of things that come to mind looking at this X-ray, Mahesh, would be that this pelvis with both femur X-ray has multiple lytic lesions. So I would, in the sense, first of all, be wondering what is happening here. But if you say that it is an inflammatory arthropathy, and I cannot see if the SI joints are intact, so probably this is an angstpond. And in that case, I would like to know, get X-rays of the lumbar spine and see what is the status of, the general disease per se in this patient. Because if this patient is an angstpond, and if they have the lumbar spine often is either straightened or flexed, then that would have a bearing on how I would plan the hip arthroplasty for this patient. So first thing first, I would like to assess the lumbar spine, would like to see the dorsal-lumbar junction. If this patient is an angstpond, I would definitely like to see what is happening in the spine, because that has a bearing on the type of anesthesia and what needs to be done there. And especially if the lumbar spine is flexed or if it is even straightened out, that would have a bearing on the position of my acetabular component. And then I would like to see the markers. And the other thing is that there are multiple punched out lesions in the entire pelvis. I would be wondering what exactly is this. So I would definitely like to, before jumping into a planning for a surgery, would like to know the nature of the inflammatory arthropathy. And once I'm sure about that, then I would actually go into planning for the hip, which would include the position of the spine. And if he or she is the angstpond, then the status of the dorsal-lumbar region, because sometimes they tend to have Anderson lesions, which can be catastrophic anesthetic risks in these patients. And then would then come down to the planning of the total hip per se, once I'm sorted with the kind of inflammatory arthropathy we are looking at.
So, Dr. Patel, what are the problems you anticipate as you start your approach? What is the next problem that you might anticipate in this patient?
So, looking at the X-ray, hip seems to be bone seems to be osteoporotic. So, first thing we should take care in the dislocation, because of the in such a protrusion there are high chances of the fractures while dislocating. So, one or two try for dislocating. If you cannot dislocate, then in situ osteotomy, and then take out the femoral head. But first thing I think come in my mind is the dislocation. Very risky and need to take that time. And it's overall,
so I think,
overall profile is very osteoporotic. So every even acetabulum preparation need to take care so that acetabulum fracture, femur fracture does not happen.
Yeah, perfect. So thanks for that, Dr. Bharath. What is the choice of implant for you on the acetabulum side and on the femoral side for an elderly patient with osteoporosis?
Yes, sir. In this situation, I said we have to tackle the Protrusio with the mossless bone graft. Bone can be taken from the femoral head itself.
Yeah.
It made into pieces around 3 to 4 mm or 4 to 5 mm pieces, and they are medially packed. Maybe we can use a reverse reaming, or you can gently pack it, make sure that you don't violate your medial wall. And the choices are 3D profile cup or uncemented cup with preferably multi-hole, or a 3-hole is enough if the fixation is good. And on the femoral side, as I already mentioned, it's a wide canal type C. Preferably a cemented processes on the femoral side would be an ideal choice in this particular case.
Okay, thank you very much. So let's see what we did.
Mahesh, I have one more comment to make on that. You asked about the precaution. Yeah, the osteotomy is a better way. I don't even waste time in trying to dislocate. I do the double napkin ring osteotomy, double osteotomy, and take it out. It comes out comfortably. And the word of caution in this kind of protrusio, and especially if it's a thinned out medial wall, you always bet on peripheral fit. You don't want to lose that peripheral rim fit for stability, because you don't want to depend on the medial wall or the dome for the stability, because you want to stop the migration. So peripheral fit for me is very important.
Yeah, completely agree. Don't hesitate to perform an in situ osteotomy. Don't try and push the hip in dislocation. There are stems which allow you to get into DOR-C canal as well. Or you can use a customized stem. Yeah, Dr. Mohanty, please. Yeah.
Yeah, just whatever I told, I just add one or two things. While exposure, one has to be very careful about sciatic nerve while going by posterior approach, because the sciatic nerve remains close to the posterior aspect of the femur in cases of protrusio. Number two, dislocation might be difficult. One have to may have to take out the osteophyte, so dislocation becomes easier. And number three, while reaming, one has to ream the mouth only, don't have to ream the floor, because floor is very thin. One has to be extremely careful, otherwise one may breach the floor. They are the three things I wanted to roll in addition to that, whatever has been discussed.
Okay, thank you. So this is exactly what we've done. So no hesitation for a cemented stem, uncemented cup with bone graft. We followed all the advice as suggested by the various panelists, achieving a rim fit cup, bone grafting of the acetabulum with the femoral head, in situ osteotomy, and try and make the experience as safe as possible for the patient. So similar case, I think even more trickier. So ladies struggle to walk like this since childhood, but didn't really present to us till her 60s. And as you can see, there are issues here. So I'm going to talk to Dr. Anil. Anil, can you comment on your thought process for tackling such a deformity in an elderly patient?
Surprisingly, Mahesh, the X-ray on the femoral side, the bone stock looks quite good, in the sense the cortices are fairly thick. It doesn't look porotic, and that's a big plus for this particular patient. The eyes are wide open, as Ronak calls it, so it's a significant flexion deformity, obviously on both hips. The spine is flexed. And in addition to what all we have discussed for the previous protrusio, this would require a really extensive release. I would go posterior for this, because I would like to release circumferentially. Otherwise, I would not be able to restore the center of rotation both for the femur and the acetabulum. It'll be, unless you do that release, that offset will not be we will not be able to restore the offset, because it's been staying this way for a very long time. And obviously, I would keep stem with a short offset, which means a small offset stem, either low offset primary or something where I can adjust. I would anticipate version problems also, because it's been this way. So I would like a modular stem also to be kept in. A CT scan may be helpful, especially when it's a long-standing one. So my go-to would be, especially because the femoral side looks okay, an uncemented cup. Again, dislocation, be very careful. Need plenty of release, because we need to get that center of rotation restored. What we call a 360 release, and then a modular stem.
Perfect. So let's see what we've done. We've used bone graft. Again, acetabular technique is exactly the same. And we have used a CDH stem. So as Anil has picked up, the offset is going to be an issue here. A cemented stem will allow you to sink it in, use a CDH kind of design, so that you don't struggle while reduction. So Dr. Vivek mentioned as well, the Coraya stem in India currently routinely is only available in standard offset. And the smallest Coraya stem, which is size 8, sometimes size 6, has a very big medial offset. So if you use it in such a situation, you will land up in trouble. We have requested them and they have actually given us the small offset Coraya stem, which will allow you to be used in Indian female patients. But it is not commonly available.
Low offset stems are available, Mahesh, and that has really become a big bonus. Big bonus.
So after a lot of persuasion, we've been able to get the small offset Coraya stem. And so if you have a patient who is of a small stature or a protrusio or a deformity with a smaller offset, then you should consider using that small offset Coraya stem. Active stem is available, as Dr. Vivek asked us. Unfortunately, it's very expensive as compared to what we get with Coraya. So we are not using it routinely in my patients. So, and we all probably do posterior approach and sometimes a modified hard hinge approach. So we are not really looking for a stem which is compatible with our approach, such as a direct anterior approach. Yes, Anil.
Just a quick addition, Mahesh. Just looking back at that femoral X-ray preoperatively, even a size 8 corail is difficult to broach sometimes in these narrow femurs. I just so that the message goes out clear. So I start with the 6 broach, go on to an 8 carefully, and especially in an elderly person, I wouldn't want to keep broaching and trying to. The last thing you want is to break or crack the femur. So I'd be very judicious in getting that 8 also in.
Yeah. So perfect. So any comment, Dr. Mohanty, that you want to make at this stage?
No, that looks okay. That the screw is a bit of a concern, but most of the time the screw usually it is okay because the iliacus muscle is there, or else it looks okay. And coral stem now they have rather high offset stems available in coral. In these collared stems they have got standard offset and a high offset, but low offset stems are very expensive, as you told. That's okay.
Yeah. No, the cost is not the problem. The availability, it's there.
It is there. Yeah. Dr. Mohanty, the low offset Coraya stem is here. It's available with a collar.
It's available. The cost is not an issue.
And the results of the collared Coraya stem in the Norwegian Arthroplasty registry published today is excellent. Probably better than a non-collared Coraya stem. So at 30 years,
especially in geriatric population with little, if the bone quality is not very good, they recommend to use a collared coral stem so that it prevents subsidence and maintains the version also. The rotational stability is there. These are the two important, advantages of a collared stem.
Yeah. So just the general message is prepare for your operations. Don't rely on intraoperative inspiration to sort your problems. You need to plan. You need to have a plan A, B, and C, and only then go ahead with your hip replacement. So this, I'm going to skip because this is not a problem in the elderly patients. This, let me just skip through these ankylosed hips. So this is the problem with elderly patients. And this happens in our country. Sometimes you see a patient who has had an excision arthroplasty done for a suspicious tuberculosis, suspicious infection. The diagnosis is never sure. But you see the patient limping away. The opposite hip is arthritic. That has been sorted. And now this hip is an excised hip, presents to us. So I'm going to start with Dr. Bharath again. What do you think? What would you like to do for this one?
This excised hip seems to be quite long-standing because of the lot of remodeling which has happened in the acetabula part. So, as a part of a preoperative planning, I would love to do a CT scan of the pelvis to know the extent of the medial bone stock and to see the extent of deficiencies in the posterior superior wall. And of course, on the femoral side, the lesser trochanter seems to be intact. There is a significant good amount of bone which is available to the in the calcar region. And since it's a long-standing, our difficulties is going to be how we are going to reduce this particular hip. So as a part of a pre-operative procedures, rectal tenotomy before the surgical exposure could be helpful. And the options of a subtrochanteric osteotomy for erection should already have a part of a pre-operative planning. So once we expose, the difficulties is, as I said, it should be complete release 360-degree release, including the iliopsoas has to be released from the retrotrochanter, and image intensifier might be helpful in locating the cup position, and preferably we require a smaller bantam cups of 44 or 46 to have a good purchase on the acetabular side. Uncemented acetabular cup is preferable on the acetabular side, whereas on the femoral side, since we are expecting for a subtrochanteric shortening, a modular stem like an SROM or any other long stems could be an option to be placed.
Okay, yeah, thanks. Abhay, what do you think? What kind of implant would you choose for this patient?
Yeah, so this patient on the cup side, the one thing that I would also remember is post-tubercular situations, they are a little tight, and definitely they do not have the margin and the play which normal hips do have. That's the first thing that comes to mind. The second thing is, if you see the level of the lesser trochanter, it is superior to the teardrop. So obviously this hip, because of its long-standing issues, is tight. And as such, it would need a 360 release to come down, and I would have a low threshold to do a subtrochanteric osteotomy and do a modular stem here, like an SROM, which I would keep in my armamentarium for this patient ready. The other thing is that I would accept a slightly higher hip center in this patient because I don't want to stretch out the sciatic nerve too much. And I would have to do a slightly medial protrusio technique to get in a cup in the correct inclination and version.
Okay, yeah, thanks. So you think the subtrochanteric osteotomy might be necessary, but that's fine. I'm going to request Dr. Vivek to comment upon his choice of surgery for this patient.
No, for this excision arthroplasty, commonly one mistake people do that give a preoperative traction. Please remember, preoperative traction doesn't have a role in excision arthroplasty. Rather, I would take a traction X-ray, hold the femur, give a traction and see that how much it is coming down. That is important. Number two, what BHARATH has told that you have to do a CT scan to see the acetabular bone stock, and you have to keep small cups standby, because you have to ream and see that what size cups fits well, and it may require a subtrochanteric osteotomy if the shortening is too much. But usually in this type of cases, when the excision arthroplasty is done at the adult stage, they do not require a subtrochanteric osteotomy. Usually we get the femur down to the acetabulum. If you do an adequate release all over the femur, except the abductors, you can release everything on the femoral side so that the center of rotation comes down. And if it is tuberculosis, post-operatively, I would like to put these patients on anti-tubercular treatment for about 3 to 6 months in order to prevent their recrudescence.
Yeah, thank you. So look, we have talked about, yeah, I would agree with Dr. Mohanty that I would not put this patient on traction. These usually surprisingly come down because their hip has been developed for plenty of years before the excision was done. So that is why we don't need to worry about bringing this hip down. So what happened during surgery was, obviously I had a small crack in the calcar. We could get away with a standard cup, uncemented. We used a cemented stem, and we tried to equalize the leg lengths, and patient has been happy with this outcome. Another similar patient. Here, I think it's going to be a little bit tricky to bring this hip down because he's had a childhood excision. You can see the offset on the opposite side. You can see the inclination of the pelvis. So Anil, are you there?
Yeah, very much, very much. Can you hear me? See me?
Yeah, I can.
I think the X-ray is pretty obvious. The hemipelvis is definitely less developed than the other side. The femoral canal is much narrower. Mahesh, you rightly, it's a childhood problem. This definitely would require detailed planning, and because the femoral bone stock is good, narrow, I would definitely go for restoration of the hip center. And definitely first thing would be a 360 release. And after I do the release, if it's not coming down, I would what I would do is I would prepare for an SROM, because obviously the canal is narrow. I would not like to do a cemented or a non-modular stem. Then I can go ahead with the subtrochanteric osteotomy if the release doesn't work. That will also on the established side, I would take a CT where I can get the best bone stock, restore the hip center. I would keep the bantam cups ready because that would be required. And obviously it's going to be a smaller cup. Get a good bone stock in the native acetabular bone stock itself, restore, and obviously prepare the femur. If I'm able to get a 360 release, get it down, yes. But otherwise, proceed with a subtrochanteric osteotomy.
Excellent, thank you. Dr. Vivek, I just saw him.
Yes.
We missed him for the last case, but he's working and helping
No,
us.
I was listening. I was listening. I have a comment on that. Go ahead with your question.
Yeah, so what do you think would you be doing for this one? What are the thought process behind sorting out this hip?
What I would worry is this is long-standing. I don't think this is going to come around by 360 degrees or chinotomy. We can try. I don't know if any of you have tried. We don't luckily see too many of these. Have any of you tried putting a skeletal traction, lengthening it before taking into the definitive procedure? That's one question. And the other one would be sorry,
unfortunately it won't help, so we have not gone that path.
So I would say I would make all the arrangements to do the subtrochanteric osteotomy and shortening rather than put the patient through risk of neurovascular injury or a stretch, and this patient probably is going to end up with that. And I would not worry about matching the high offset too much. If we can even achieve more than half of what is there on the other side, we should be happy about that, because the musculature and tendons are used to it, and we don't want to aggravate the situation by trying to match the high offset on the other side. And I would go with an SROM kind of a modular stem would be ideal for this patient, especially antiversion is going to be a biggest issue. So I wouldn't try even doing a cemented stem in this, because the rotation would be really awkward. And we had to be very careful on the acetabular side too, because of no stimulus on the acetabulum. It is not well formed, or there is no strength to the acetabular medial or the wall. So you have to create one and be careful on not violating it or worry about the migration.
Yeah. So thank you. I think we followed what Dr. Anil and Dr. Vivek suggested. So we went for exactly like what he mentioned. So we went for a small diameter cup, uncemented cup. We used an SROM. We did a femoral shortening osteotomy, and the middle segment, we leave the soft tissues attached to it, bivalve it, and wrap it around the osteotomy site. And then, as you see, we followed him up for nearly, he's still under follow-up, but at 2 years, you can see the osteotomy is completely healed up. So if you leave the soft tissues attached to it, you get an excellent result. And there is another similar case with bilateral excision arthroplasty in this gentleman at a very young age, middle 60s. You can see severe porosis. The acetabuli are well formed. And we did a bilateral subtrochanteric femoral shortening even for such a patient. And then he will unite. So the technique in brief is you ream longer than the length of the stem so that you can remove the middle segment, mark the rotation, because rotation is a crucial issue before you make the osteotomy. As I said, you biwall the osteotomy, and once you reduce the hip joint, see how much is the overlap, and then wrap around the osteotomy site with the biwall fragment, and they do go on to heal. So we've covered that. So we've covered failure of proximal femoral fractures. We've covered a Protrusio scenario. We've covered dorsifemoral canals in elderly patients, which provide a unique problem to us. We have covered excision arthroplasty, which fortunately now is becoming uncommon in India. Not many people are excising the hips because we know how big a disability it is. This, however, is not an uncommon problem. So I'm going to ask Dr. Patel, because he's really been quiet for a while, to tell us about what he would do in such a hip.
So looking at the X-ray, to be type 3 dysplastic hip with sclerosing superior acetabulum margin. So in this case, I would definitely go with the hip center rather choosing the native acetabulum hip center, because if I put the place, then I need to reconstruct the superior dome either with the augment or bone graft. At this age, choosing the hip center will make job very easy, and the femur side is straightforward. So I will definitely go with the routine implants with the hip center on both sides.
Okay, so high hip center is a good idea. Dr. Bharat, do you agree with the high hip center? What is your thought process? Whether you would accept a high hip center, would you bring the hip down to the native acetabulum? What do you think?
Preferably, it is always better to bring it down. In these situations, I think in this particular case, we can accept up to 1 centimeter high center of rotation. We can accept. Our intention is also good stability of the cup. That is more crucial than having a center of rotation down. In this particular case, already the center has already shifted more than 50% from the native center of rotation. Stick on to the basics, do a CT scan to know the posterior superior wall and the posterior wall, and medialization of the cup. Have a smaller cups like bantam cups, 40, 42 cups, and uncemented stem should be.
Yeah. So, Abhay, what is your limit for accepting a high hip center? How high? Medial or lateral?
1.5 to 2 centimeters normally. And here the best bone is where the sclerotic margin would be. So high hip center is a good plan here. And the only other thing is that you might have to do a slightly extra release and keep a high offset stem ready in the armamentarium.
Yeah. Anil, what do you think? Your thoughts on this case?
Yeah, I would go, basically, I would put it this way. I would aim to restore the center of rotation. In the bargain, if I get a higher hip center, I would accept it, because I find it very difficult, and I've always said this, and we've you showed that subtrochanteric osteotomy also. That's why we put out a paper. We published the paper on our series of subtrochanteric osteotomy. You saw that, and that was essentially restoring the vertical and the horizontal offset. And that also we mentioned on the, it's in bone and joint. So that also we mentioned on trying to get the hip center back. I think anything above 1.5 tends to get that. Yeah, that's what. So the bone graft is there, everything is there. So we don't have to do anything extra. We just have to, in terms of cost or anything, the head is there. We can use as autograft, get back the center. In the sense, this is actually an acceptable, or within the acceptable limits of what we refer to as a normal, because anything above 1.5 becomes a high hip center. Once we get down the release and get your homins into the teardrop, the bottom, then I think the best fit cup from there with a little bit of uncoverage, which can be obviously augmented with the bone graft, I think that's the best option.
Yeah. So I agree with you as well. I bring down the hip to the native acetabulum if it's easily possible. With the modern cups, I mean, this was done about 14 years ago. So you can see that it's a Durolock cup, it's a C-stem, and the Durolock cup is a sub-hemispherical cup. So
160.
you would be able to, yeah. So So you would be able to get it in deep inside, well covered. But with the modern bearings, with the modern coatings that we have are on our cups, even a 60% contact, I wouldn't worry. The bone graft may not serve any purpose in the long term, although I have used it because unless it is loaded, it won't be absorbed. Dr. Vivek, do you want to come in?
Yes, I just, I mean, I agree with what you guys all said. I would like to bring it down for another reason. The more higher you go, you don't have a good fit and coverage. So your cup will be more naked than if it is lower. Anterior and posterior wall are better on the lower. As you go higher, all you get is a medial wall and you're asking for trouble. So I would rather try to stay lower with whatever way you can, and that'll be a last resort to go higher. So the anterior coverage is in a much better shape. I would have put a little bit more anti-version to it.
Yeah. Okay, so I think both are good concepts as long as you're comfortable doing it. If you're accepting a high hip center, so don't obviously, as you've said, not more than 1.5 to 2 centimeter, and never lateral. So if you accept a high hip center, it has to be medial. It cannot be high and lateral because that will unfortunately fail. But again and again, yeah, Dr. Mohanty.
Yeah, you know, the recommendation is that it's a Crow type 1 and type 4. You restore the center of rotation. Crow type 2 and 3, you can accept high hip center.
Absolutely.
This is the usual recommendation in the literature. And regarding the graft is that, you know, whenever you are putting graft, the screws has to be directed towards the sacroiliac joint. It has to be in the, you know, direction of the bone trabeculae. That is important. And as you rightly told, Mahesh, that, you know, the graft has to be loaded. If the graft is not loaded, then it will get absorbed. And when the graft gets absorbed, then the screws come out, the screws become loose. So while putting graft, one has to be very meticulous enough to put the grafts. And the size of the cup depends on the anteroposterior diameter here, not on the superior inferior diameter. So commonly, you know, mistake is done, they go on rimming and the cup goes higher and higher. So if the anteroposterior column is intact and your rimming and your cup fold is good in the anteroposterior diameter, that is the size of the cup, then you try to build up the superior gap or, you know, build up with bone grafts or whatever. Yeah. And the dual cup in this particular situation is, as you have rightly done, that it's very helpful, 160-day dual cup. If it would have been a pinnacle cup, then it would have been overhanging more and uncovered. That's all.
Yeah. So, look, I have been showing X-rays of a cemented stem quite often, which I think is right for geriatric age group. So I feel cementing is a good art. The North American continent, probably the North Americans probably don't cement as much as we do, or the European countries do. But I think cementing still remains a good option for patients. So let's now hopefully conclude with this case, because we got last 3 minutes.
Yeah, Mahesh, this can be the last case for you, please.
Yeah, last case.
Thank you.
So we have a situation here. We have an intertrochanteric pertrochanteric fracture. So I'm going to quickly start, and one sentence answers, please. I'm going to start with Dr. Patel. What is your treatment choice here? Fixation?
Replacement.
Replacement, and why?
Because the hip is arthritic.
Okay, perfect. So why not fix it? Yeah, so I'm going to ask Dr. Bharath, why not fix it and come back and do a total hip replacement later?
What is the age of this patient?
Mid-70s.
Mid-70s. It's already arthritic, even if you want to fix it.
We can't hear you well.
I'm now able to.
Yeah.
The hip is completely arthritic. It is going to be a one procedure.
Okay. Abhay, what do you think? What would you do for this one?
Yeah, I would replace it without a doubt. It's already an athletic hip, and sometimes that the fracture of the proximal femur as it is probably as a result of the stiffness and the arthritis in the hip. So that's why
one
they need
sentence
a hip.
answer, please. Yeah. We are running out of time, and I'm getting constant beeping here.
So do a distal fixing stem for this one with an uncemented cup. You just need to keep a high offset stem ready, or be able to dial in a better
one
offset.
short answer, please.
Template, high offset, avoid the fragments, good fixation stem. I would use a polar if necessary, polar stem.
Yeah, Dr. Vivek.
I would do all the things they said. Do a calcar replacement because it's pretty low, and it's better to get the length. And also, I worry about the trochanter. I would put a claw plate in there, just wrap it around, so keep the abductor mechanism intact.
Yeah. So I think we did somewhat similar. We used fully coated stem with somebody's mic needs to be on mute. Yeah, can we switch off the mic? Yeah, so we finished with uncemented stem and cup. We like to please our North American guests, so we like to use uncemented hips as well sometimes, Dr. Vivek. So thank you very much, all the faculty.
You'll come around.
Yeah. So
and you'll never go back to the cement.
So I really thank Dr. Abhay, Dr. Vivek for sparing time and being there on this webinar. Dr. Mohanty, who has been traveling. Mumbai people never get a rest. They are traveling from one hospital to other, very busy. Dr. Patel, Dr. Bharath, and Anil, thank you very much. And we hopefully try to keep it as general as possible without trying to go into nitty-gritty of arthroplasty surgery. So thank you very much. Thanks, Dr. Dave and the GOSICON.
Yeah, thank you, Mahesh. And all the Mahesh and all the colleagues, Dr. Anil, Dr. Karthik, Bharat, Dr. Mohanty, Abhay, and Vivek, thank you very much for joining for a wonderful session. We just quickly, before we go for the next session of the knee, which is to be chaired by Dr. Rajkumar, there was some technical problem with the introduction when Dr. John EBNEZAR was going to just give a welcome note. So he will just take few minutes and we start welcome speech from him, and then immediately in next few minutes we will switch over to the next knee session. Dr. John, please.
Yeah.
John.
Yes. Can you hear me?
Yes, please.
Yeah. Sorry, had a technical issue. Could not present the update at the beginning. So I welcome you all to the 9th International Conference of GOSI and the 2nd Virtual GOSICON 2021. So the Geriatric Orthopedic Society is formed because it is one of the most required subspecialty because of the long lifespan what we are now all having. So bulk of our practice is around geriatric population. So the need for Geriatric Orthopedic Society of India. So this has grown by leaps and bounds for the past 9 years, and we have got presence in almost 7 countries now, nearly 1,000 members. So myself and AMARNATH were the ones who organized and who floated this organization. And this year's 2 years of presidentship was managed by Dr. DEEPAK Dave, and Bharat Dave was the secretary of this organization. So we had our first GOSICON in 2013, and it was graced by Dr. Sancheti, NS Lord, GSK, and VMIR. Then second one was in Bangalore Medical College. Third one was at Bangalore. And the fourth one was in Bhubaneswar. And then fifth one was at PGI Chandigarh. And the sixth was at All India Institute of Medical Science, New Delhi. Dr. Rajesh Malhotra.
John, your slides are not moving.
Not moving. But slides are moving here. Slides move on. Hello?
Deepak, anybody? The slides are moving or not moving?
Slides are not moving?
Yeah, just in the slides, sir.
Sir, make a full screen.
Full screen.
I have made it full screen.
No, go to the slideshow.
The slideshow, I have made a full screen. Press the presentation again, sir. Now, can you see? Opening slide.
We can see the slide is not moving.
It's not moving.
Sir, once close the presentation and open it again.
Close the presentation. Open. Close the-
Any-
Can you see the slides now?
No, it's the same screen.
It's your first slide. Nothing is moving.
Full close my presentation.
Sir, if you could share me your presentation, I will show behalf of you here.
I think, John, better you can just pick whatever few things you need to mention, please.
It should be good.
Yeah.
Okay, fine. Hello.
You're talking about AIDS. You said the conference was in AIDS, and I can continue
Hello.
from there.
John.
Yeah. I don't know what is happening.
Joe, it's okay. You can start from AIDS and then continue.
No, I don't know here. Now the slide is not moving here also. Stop sharing. I'm stopped. Yeah, I'll share again. Can you see now?
Yes, sir.
Can you see?
Yeah,
Yes, make it a full screen, sir.
Yeah. Now is the slide moving? Now is the slide moving?
No, no, no.
It's not moving. Okay,
No.
then I'll just I'll read and finish it off. Right. So this is the second virtual conference, and the team of GOSICON 2021 is very dynamic. We have Dr. DEEPAK Dave, BHARATH Dave, and his team of Yuvraj, Lakhum, and Ajay, Krishnan. Program of GOSICON 2021. The highlight being a fully interactive conference. Day 1 is arthritis day. Day 2 is trauma. Day 3 is spine, osteoporosis, and pelvic fractures. Yes, DEEPAK has ensured that there is no didactic lectures. It is going to be only case-based discussions and debates, panel discussions, and free papers. And oration is going to be by the IOA President, Dr. Shiv Shankar. Highlights of the conference, our ortho and our scientific partner is OrthoTV. We have got over 300 registrations, and eminent faculties, international, national, and local international faculties from over 7 countries. Second virtual conference to be presented with CME credit points. So we have done CME programs worldwide, and we have got various activities lined up through GOSI. And as a subspecialty, we are trying to promote geriatric orthopedic practice. And yeah, I urge all to become the members of GOSI. And I invite you all to participate in this international second virtual conference. I thank all our academic partners for supporting us: Gujarat Orthopaedic Association, Ahmedabad Orthopedic Society, Spine Association of Gujarat, Indian Musculoskeletal Oncology Society, and Fragility Fracture Network. GOSICON 2022 will be organized by my very good friend Dr. Bandekar in Goa, and all are welcome there. So I thank you all for attending this second virtual GOSI conference. I request Dr. DEEPAK Dave to please go ahead with the next program. Thank you.
Thank you, John. Thank you for the nice introduction and brief for the GOSI. This is the second session of the knee arthritis, and the moderator for this session is Dr. Rajkumar from Ganga Hospital, Coimbatore. We have eminent faculties: Dr. Bharat Modi, Senior Arthroplasty Surgeon from Baroda, Dr. Srikanth from Bengaluru, Dr. Neeraj Agrawal from Jaipur. We have Dr. Kirti Shah, who is the consultant orthopedic surgeon at Warwickshire Hospital in UK. He accepted our last minute request and joined here. Fortunately, he is in Ahmedabad. And Dr. Yogesh Kamath from Manipal. So we have quite illustrious panelists here, and I request Dr. Rajkumar to take over this session. Dr. Rajkumar is there? Dr. Rajkumar?
Off ಮಾಡಿ. ಎಲ್ಲ ಸತ್ಯನಾಶ ಮಾಡಿದ್ರು ಎಲ್ಲ ಪ್ರೋಗ್ರಾಮ್ಸ್.
Spoke to him about a couple of minutes ago, so he should be there only.
I can't see Rajkumar. Hi all, while waiting for Deepak to come back and then get the...
Yeah, just got the message. He's just joining. Yeah.
Fantastic, fantastic. So I welcome each and every panelist for the second session of Arthritis Day. Fantastic going, guys. And Deepak, thank you for being the timekeeper, and you are hitting the nail on the head, literally. And good going. I think Rajkumar is going to be joining us. And it's nice to have a fantastic panel across. And we had a very interactive discussion. I think I'm sure most of you have joined in the first session. And it's going to be much interesting now because more than hip, Indians do have more knee challenges. Rajkumar is here, is it? Oh.
Yes, Bharat, how are you?
Hi, I'm very well, thank you. Looking forward to the interactions.
Correct.
In fact, I was not aware that we have a society on geriatric orthopedics based out of our country.
Yeah, this is a baby which is 10-year-old now, and trying to, as Dr. John EBNEZAR just mentioned, the previous meetings have been at the various places like Bhubaneswar, Chandigarh, Delhi, Bengaluru, and this 2 times we have been doing virtual from Ahmedabad. So the whole idea is to basically, yes, Dr. Rajkumar has joined.
Yes.
Can you just start sharing the screen?
Yeah. Now doing.
Okay. So the whole idea is basically to spread the awareness of this specialist subject to all across the India. So Bhubaneswar, Chandigarh, Delhi, Bangalore, Ahmedabad, we have been trying to keep the conferences at various places. As you see in the program, we have Arthritis Day, then lots of spine cases to be discussed, osteoporosis, and the trauma, geriatric trauma. Tomorrow also we have a wonderful faculties, Dr. John Mukhopadhyay, Dr. Devendra from Coimbatore, Chatterjee from Bangalore, and so many other people are there from Gujarat, Anil Shah, Dhaval Desai. Everybody is going to be there. So it's a trauma plus arthritis. After this, we have a session on shoulder, which is to be conducted by Ashish Babulkar. Yes, Dr. Rajkumar. I can't see him. He was here.
Oh, he's gone again. He's gone again. No problem. But Dr. Bharath, in fact, next year we are going to be in Goa, as John was mentioning. It's going to be a physical one, and then we can have best of the best, and we can have beautiful beach parties and enjoy the Goa hospitality.
So, in the meantime, Rajkumar comes. Actually, I was just thinking that why not we start our discussion part, which Rajkumar, when he comes here, we will stop it. So one very basic question which comes to my mind is that we are like discussing total knee replacement in geriatric orthopedics, but then how to correlate the TKR with geriatrics, because all our patients are 60, 70 and 80 years. So we can start from Dr. Bharat Modi, that how he feels that geriatrics is different in when we talk about total knee replacement.
So very good question, and I'll start with this. I consider if you want to put the criteria as age, and which is a fair criteria to take. Although all of us know sometimes a relatively young person will have the same features as a super geriatric, but I would consider for the purpose of discussions of a specialized platform like this, cutoff age at 75 and above, and certainly anyone above 80 would be classified as a super geriatric, which is where the real focus of interest should be on a platform such as this. So 65 is actually almost young. We shouldn't be spending allocated time on that. Now, coming to that,
yes,
real challenge to me are nothing to do with the technical aspect of knee replacement. That's hardly 10% of the challenge. The real challenge are things such as in old age, reduced cardiac capacity, a tendency to go in for a decreased sodium levels, post-surgical drop in the sodium levels. The challenges such as how would you manage the transfusions of crystalloids, colloids, or blood, considering that the cardiac vulnerability of overloading. How would you do your rehab? How would you look at the peri-operative mental confusion and disorientations, which is so frightening to the patients? So these are the real challenges of super geriatrics, when it comes to knee replacement or even hip replacements. As orthopedic surgeons, we often end up intuitively focusing only on the technical aspects. As I was just observing in the last hip session, it was all about whether it is a high hip center or a low hip center. In the super geriatrics, the challenges would be dislocation, for example, and why dislocation is a higher risk in the super geriatrics. So let's see how Rajkumar is with us, and we have an excellent moderator. So let's see how Rajkumar handles.
Yeah. Rajkumar, can you just share your screen and start, please?
Yeah.
Thank you.
Yes, sir.
Hello.
Hello.
Is it Kaustubh?
Yes, good evening, sir.
Good evening,
Yes, sir.
Kaustubh.
John, can you unmute yourself? John, can you unmute, please?
Yeah. 1 minute.
Yes, start, Rajkumar.
Good evening, everyone, and sorry for the delay. There was a small technical hitch. And without wasting much time, I would like to start. And before starting, I would like to thank Dr. DEEPAK Dave for inviting me to this fantastic program on geriatrics. So my topic was case-based discussion on knee arthritis and challenges in the old age group. So I was just hearing Dr. Bharat Modi sir speaking about the challenges, how exactly we are facing in our day-to-day practice in knee replacement or any total joint arthroplasty. So if you look at in a severe arthritic knee, whether it is a varus or a valgus arthritis, we all know that patient needs a total knee replacement. There is no doubt about it. A total knee replacement is a must. So the question comes is whether old age or a younger age group, if they need a surgery, they have to have it. But the problem is how we are going to manage it. Two aspects. One is preoperative, perioperative, and postoperative. All the three put together, the outcome is good. So here in this session, we will it is related to technical point of view, because arthritis and old age goes like hand in hand. And the medical part, since we will not be able to discuss too much on the medical management because it differs from patient to patient, and those kind of case scenarios we may not be able to exactly replicate, but we will try. I have compiled a set of cases to make sure that these are the things which we will be encountering old age group. So I will try to. So the topic here is challenges in old age. So actually, which age is old age? We can see nowadays in India, like a lot of old age patients, they are physiologically very active. Younger age group, like 50 years, 55 years, are very sedentary lives. Because of the sedentary lifestyle, their entire medical part and the bone part, everything is so much different from the old age group. So we actually find it the other way around. We find scenarios the other way around. And because of the life expectancy is increasing in India, And our old age nowadays have started to live by themselves. Like they have now going towards retirement home, where they spend more time going outdoor activities, and they have their own peer group. So they spend a lot of time outdoor also. So we need to tackle these kind of arthritis in this old age group. So if you look at the literature also, they have concluded that patients with good functional status and minimal medical comorbidities. So our set of cases today will be of minimal medical comorbidities with good functional status. Age alone should not contraindicate knee arthroplasty. So these are the set of cases which we are going to see. So in these set of patients, how we are going to deal with. So that is what. So to start with, 81-year-old female, even though the age looks 81, like old age, if you look at the X-ray, arthritis is there, patient is painful, definitely needs a total knee replacement. So to start with, anything to add apart from total knee replacement? Yes, as a pre-operative measures. Dr. Bharat sir.
So Rajkumar,
yes,
I said just a little while ago,
okay,
that for the purpose of discussions on our platform tonight, I would ask you, is there anything specific at 81 that you would mention is definitely correlatable to old age? For example, are we talking about any serious medical issues, or I just take it for granted that that's all okay?
So that's what. So here I have compiled a set of cases where the medical management, I have included that also here, but we will not go into too much about the medical part alone, because
fair enough. Then you have answered my question. So my answer to your question would be, if this lady is painful, I would recommend a posterior stabilized standard total knee arthroplasty, and I don't resurface my patella. So I would probably not resurface in her case as well. And that's my answer. And it's otherwise a very straightforward looking case. On the grounds that the soft tissues are normal as they look to be normal on this thing, and you haven't mentioned anything specific about soft tissues. So
that part here the thing is regarding as you said, sir, that it is a straightforward knee replacement surgery. The only question is, since it is an old age, arthritis in old age, the question of whether to do a CR or PS, like we all know that there is always a big debate about CR and PS. So here I would like to ask Dr. Kirti Shah from UK about his thoughts on CR versus PS.
Good evening, everyone. Thank you for inviting DEEPAK. It's a wonderful meeting. I'm very impressed. I think before I answer that question, I would just add that it would be nice to add ortho geriatricians or physicians with interest in geriatric medicine in this forum, because their input would be very helpful. Coming to this name, this patient has painful knee, and your primary aim would be to try and relieve him or her of the pain. I would rather do minimal intervention and give her or him a pain-free knee joint. The question about the debate about PS or CR is quite difficult to answer. My concern would be, since been practicing knee surgery for a long time, I've recently moved to doing a CR knee in most of the patients. The reason being that this patient doesn't have a severely deformed knee. He or she probably has a good PCL. Sacrificing that is not mandatory. It's not essential. You might give her a good proprioceptive sensation if you preserve the cruciate. Other thing is that in an osteoporotic bone, I'm quite concerned about making a big notch when you prepare the femur. I feel that doing a CR against comparing the results of the PS, the end result is equally good. So my suggestion would be, why to create more trauma to the knee joint by doing a notch cut, which you can do without. The end results at the 81 years of age is no difference whether you compare CR or PS knee when you assess them at 6 months or a year's time.
The
other thing about the patella resurfacing, if the patient has significant patellofemoral degeneration, then I might consider Otherwise, doing a denervation of the patella gives them good anterior knee pain relief. So I would not be keen to replace the patella in most of the cases.
Okay. Okay. Thank you. I'll come back to that point. Dr. Kirtisha. Sorry, Dr. Yogesh. Dr. Yogesh.
Hi, Rajkumar.
Hi.
Yeah, so I definitely the concerns when doing an 81-year-old are medical, and you've rightly pointed out to that. What are the most concerned, and in my experience of doing octogenarians, if a person asks for a TKR at 80, they are usually medically better than the average 65, 70-year-old who can have many other problems. So they're actually gutsy, and I have seen my 80-plus-year-olds actually recover better than the average 70-year-old obese ones. That is number one. Number two, I wouldn't change my design just because the patient is older than 80. I'm a routine PS knee doer and a routine patella resurfacer. And I think if I can give consistent good results with that, I would stick to that. Just because my mother is 80 and she has been wearing a sari all her life, I cannot ask her to change to a short skirt. So why change my culture when I can routinely do it and offer reliably good results with what I routinely do? Okay. What I wouldn't do in cases like this is do fancy things like try some new fancy implant, try something like robotics or whatever, which I think might be unnecessary waste of time. The advantages of all these new fancy techniques is probably get better alignment and get better longevity, which is not important in somebody more than 80. It is important to get a consistent good result and early recovery from the operation with least medical intervention. Okay. Yeah. And, designs like patella PS or CR and patella resurfacing are a matter of individual culture. We know that there is no difference in the results either way. So whatever the surgeon is used to doing and can provide a consistent result with, I think that is what he should do.
Okay. Okay, good. I will, Dr. Shrikant, your quick answer about these points.
Yeah,
because
good evening.
we have equally divided house now.
Yeah, so good evening. And basically, I think I'll take your second point first, osteoporosis. And I would definitely investigate this patient with DEXA scan for osteoporosis.
So we'll come back that later about the investigation part.
Yeah.
So here the management part about anything you will do.
I always get the long leg views. I'm not happy with just the APN lateral, what we have shown here. So I will do that as well. Okay. And yes, during my training in UK, I did train on PS, but all my fellowships, it's with CR surgeon. So I'm now an obligate CR surgeon. And with osteoporosis, I might stem the tibia. So that's an additional thing I might do. And patella resurfacing, I've been obligate patella resurfacer. Unless it's very severe osteoporosis or the patella looks pristine, then I would resurface it. And we had a great meeting just a few weeks ago about the forgotten knee joint. And, Prof. Acharya was there from Bristol. And he said one of the bad outcomes for getting a bad forgotten knee score is not doing a patella when it is arthritic. So I tend to resurface patella. Yeah.
Okay, good. So here, the whole idea of putting this case was, if all these routine debates of CR, patella resurfacing, whether it will change for an 81-year-old. So the message here is whether CR or PS, yes, whichever you are comfortable with, the surgeon is comfortable, better to do the same. Osteoporosis, yes, investigation part, we will come back to that. But for this case, mostly you don't need anything additionally. Second, and the third point, patella resurfacing, again, it differs. My preferred choice is if it is very badly arthritic, I change. Otherwise, I never routinely do a patella resurfacing. So this is what was done, a routine PS knee. So here, coming to the osteoporotic part, one point I would like to ask the panelists, is it like just because 81 years and osteoporotic, even the same kind of bones we might encounter in 60 years or 55 years if the patient is an inflammatory arthritis. So we don't do stemmed tibia routinely. So here, because 81-year-old female, do we really need a stemmed tibia? So that is what I here normally do, is put a lot of cement into the intramedullary part. So in the post-op X-ray, you can see that. So this is what I routinely do, and don't stem the tibia just because it is 81 years old. So quickly, I want a quick answer. Do you routinely stem a tibia like this? Dr. Bodhi, please.
Answer is
No,
yes.
I don't.
Okay.
I don't routinely stem a tibia just because the patient is 81-year-old.
Okay, sir. Good. Dr. Neeraj?
So answer is yes. I cement all my tibias like this only.
Okay,
it is
right.
the same.
Dr. Srikanth was telling about stemming the tibia. So do you, in this case, will you prefer a stem?
Yeah, if it's rheumatoid or if I'm worried with osteoporosis with a
No, in this case, I'm asking about this case.
Yeah, what
This
was
is
the
not a
DEXA scan,
rheumatoid.
what was the DEXA report on this?
In this, I didn't do a DEXA. It is like patient is 81, arthritic.
Rajkumar, Rajkumar, can I ask Dr. Srikanth, do you
Yes,
have
yes.
a basis? Do you have a basis to say that a DEXA report gives you an X value and therefore you will stem it, and that there is adequate data available that at a particular correlation of a DEXA report, stemming a tibia gives you longer survival? Or is it just intuition and applied intelligence?
It's intuition and peroperative. You know, if I feel that the bone is not of good quality, I always keep the stem as standby.
No, DEXA. I'm asking you a very specific question.
Yeah, not
when
on
you
DEXA.
say, because you seem to have a protocol wherein you would do a DEXA scan in a super geriatric, that means now it's not about you feeling or not feeling about a particular case. It's about deciding based on a DEXA report. And doing so, you need to have cutoff values. And to select your cutoff values, you need to have adequate data to back it up, why you have selected that cutoff value. So just explain, please, if you would.
Yeah, I don't use DEXA values as a cutoff to use a stem or not. But if the bone is weak peroperatively, I will have a stem as standby rather than not planning for it. That's what.
Fair enough. So the point is, DEXA report does not have any real value addition except just confirming what you might see on the table anyway. So to keep a stem as a standby would be a good idea as a practice measure in any arthroplasty scenario, not necessarily anything to do with super geriatrics as part of your practice protocol.
Yes.
Rajkumar, your
Nicely
comment-
cemented. I think Dr. Dave Barrett in Southampton has proved the value of cementing like this, the keel. That's a fantastic way to go about in these kinds of patients.
Yeah. Yes.
May I have a point?
Yeah, please.
Yeah. So I don't think, as per NICE guidelines, DEXA scan has very few indications in above 80-year-olds. So I definitely would do a DEXA, and I don't think it is indicated above an 81 at that age. Secondly, I wouldn't stem this. I would think of prophylactically stemming osteoporotic ones, particularly if the deformity is more, and particularly if there is a lot of tibia vara, because they are more prone to also get stress fractures, but certainly not a mild arthritis like this just because they're 81.
Okay, in this 79-year-old female, this one, osteoporotic, is little more severe varus. So do you need a stem here?
I would think about it, not only because of the severe varus, but there is a defect on the lateral tibial plateau as well. So there is certainly something complex going on here. I would obviously assess the soft tissues. Maybe it is inflammatory. It could be.
It is not inflammatory.
Okay.
It is not inflammatory. So if it is inflammatory, I will let you know. But this this case, it is not inflammatory.
But I would have a lesser threshold of putting a stem here because there is something, kind of weird going on here.
Okay. Like Dr. Kirti,
I would have a lower threshold. That's all.
Okay. Yeah. Well, I think I would go in with a plan to do a primary knee replacement here.
Yes.
If you look at the level of the tibial cut, which you can remove, you will still have a bit of tibia proximal to the fibular head. I therefore do not think that the medial collateral ligament would be compromised a lot. I would go in with a plan to do a primary total knee replacement, and on table, if necessary, we can have a medial wedge or a tibial stem, but it is highly unlikely that we would need it.
Dr. Bharat, sir?
I would stem this tibia based on my at present radiological appearance of quite significant metaphyseal osteoporosis that I am seeing here. And my threshold for stemming this tibia would be extremely low.
Okay. So you will use a short cemented stubby stem?
Yes, absolutely. Bang on.
Okay.
Yeah.
So do you need a stem? So this X-ray was put basically to raise that point. So in this case, again, I didn't stem the tibia here because I routinely see we all see these kind of cases. But as Dr. Bharat sir said, perioperatively, if the bone is very, very soft and if your tibial tray itself is trying to sink in even during the trial, then that time you can go ahead and do a stemmable tibia, a short stem, stubby cemented stem. But as we all discussed in these two cases, that a DEXA scan or a preoperative too much of osteoporotic workup may not help us to change our practice of what we do for routinely these kind of cases.
So Rajkumar,
yes,
may I add a tiny amount of information here for our audience?
Yes, sir. Please.
So, for example, if you are doing an Ayushman case, the ability to extend even 10,000 rupees more of hardware is probably limited. So in that case, what Rajkumar has just demonstrated is, or is conveyed this message through this particular case for the audience, larger audience, is that high quality cementing can compensate for a stem if you cannot add on a stem for XYZ reasons, number one. Number two, more importantly, ensure that your tibial tray seatment, the tibial tray placement, extends from one cortex to the other. In other words, in such cases, the strongest support you have is from the edge of the lateral tibial cortex to the medial tibial cortex. And therefore, for the audience, selecting the size and the placement of your tibial tray along with good cementing will easily look after vast majority of cases, even if you don't stem them. And that's the message I would like to add on to whatever Rajkumar has just explained to us.
Yes.
Just one question. This lateral X-ray shows significant patellar osteophytes. I mean, say, would you sort of resurface patellar depending on the type of the implant that you use? Like the would you resurface? What do you do?
Yeah, no, I don't routinely resurface unless the patellar shape itself is so much like one, either the lateral facet or the medial facet is completely excavated. Those kind of cases, very rarely I resurface, but routinely I don't do. I just do a patelloplasty. And
the DPU implant is not a patellar friendly implant. That's why I asked.
Yeah, I understand, but the PFC which I have used, the newer ones they have changed that, they have increased the notch area, but I don't routinely resurface, and I have not seen much of any big difference because in our centers we do a lot of PFCs and we have not resurfaced routinely. And anybody
I agree with Rajkumar, the PFC sigma, and while Dr. Srikanth is also very right, as a prosthesis, PFC sigma was, as if there is one criticism that you can levy onto it, it is this, that it's not a very friendly intercondylar notch, a box that they have. But in recognition of that, J&J brought in a new generation of femoral components wherein they turned in the edge.
Yes.
The edge was was very sharp and was looking right onto the patella itself. Instead, they sort of turned it in this new component, and they could do it without having to go through the entire US FDA, process of revalidating it, and therefore they have been able to introduce it. So all the PFC femoral components that you now get has got that slightly modified edge of the intercondylar box. And not that in itself is reason enough whether to resurface or not. To resurface or not is more about, as you know, it's a larger debate that we cannot take up an entire lecture on that or a session on that. So.
Thank you, sir. So we'll move on to the next case. It is a 78-year-old female, windswept deformity, ASA grade 2, not much of any big comorbidities except for hypertension. Otherwise, patient is physiologically active. So it's a windswept deformity. This case is basically on deformity and the management. So in this windswept deformity, I would like to get a quick answer from the panelists. Anybody will do a bilateral single stage in this case? Dr. Srikanth, a quick one answer.
I don't do bilateral single stage. I usually keep a 3 to 6 months gap between the two knees.
Okay, Dr. Kirti Shah.
Well, I would say that with the hemoglobin of 10, it will be criminal to do bilateral single stage knee replacement. We will harm this patient rather than help. Do it in a
Okay. So I think everybody will accept Dr. Yogesh. Any difference of opinion?
One at a time.
One at a time. And
one at a time. I'll definitely allow cross-legged sitting later, but once both are done, but do one at a time.
Okay. Dr. Bharat sir, I think sir also will do as a staggered one. So is it like staggered or a staged one?
So I do it in, if the patient is ready, if our otherwise medical condition allows me, I would have no compunction in doing it in one admission, which means at an interval of 3 or 4 days.
That's staggered, yes.
Yeah, that's not. I wouldn't necessarily stagger it by 3 months or a few months, so to speak, unless there are reasons for doing so.
Any of the panelists will contradict this one, the staggered path?
I certainly
yeah. So it's like this.
I think there could be more complications. Sorry.
Yeah. So in my practice, either I do a bilateral totally in one go, or I keep a gap of at least 6 weeks. So I don't do knee at an interval of 4, 5, or 6 days, because these are geriatric patients, and by the 4th, 5th day, these patients have electrolyte issues and certain other things going on, and to give a second catabolic insult at this 4th or 5th day is sometimes detrimental for the patient.
Okay.
So it has to be single knee, 6 weeks or 8 weeks gap. That's all.
Dr. Agarwal, Neeraj, I have a question for you. If the patient was 65 years old, had no metabolic disturbances of note after your first knee, a patient wants both of them sorted out in one instance,
yes, sir,
ready to stay in your hospital for 7-8 days, would you then do it as a staggered thing, or even then you would tell her or him, no, I will only do it at 6 weeks? 65 years old, no metabolic disturbances on the 4th day.
Then I will do bilateral TKR single stage. I will still not give a gap.
Fair enough. So that's a good answer. It's more about philosophy here rather than any science. To the extent, bilateral single stage. And Rajkumar, this is important for the audience, because let's go into a slightly deeper understanding of this area of discussion, if not debate. Whether staggered or bilateral single stage.
Yes.
Bilateral single stage, for all my colleagues as well as the larger audience, like so many things in our area of work, it all arises as a result of health economics rather than health science. Bilateral single stage is a method of treating bilateral osteoarthritis of the knees, emanated initially from the US. Large numbers started being performed in the US, because every day of hospitalization in the US is cost anywhere up to $10,000 minimum or more only in hospitalization charges. That started making, and then once the US fraternity starts adopting a practice for whatever reason, XYZ reason, then you will find that a plethora of supporting literature starts coming out. So the typical argument that the US-based surgeon would make for doing a bilateral single stage, which is so that it is not vulnerable to medical legal issues, is doing staggered is attempting to do something when you have triggered a catabolic status after the first surgical act. So instead, you want to load the body with 2 large operations on a single day, on a single morning, instead of trying to stagger it out for 4 or 5 days for the body to have recovered, on the grounds that it is well understood in the metabolic science that after a major insult of whatever nature, whether it is a surgical or a trauma, body goes into a catabolic status for 6 weeks. Having said all that, there is not a single paper, not a single meta-analysis which shows that a staggered form of treating these people, and this will be endorsed by 90% of the audience who is listening just now from their own practice experiences. And in India, we do thousands. There are surgeons who will be doing thousands in a year, and there will be doctors in this audience who will be doing hundreds in a year. And you would have seen it again and again and again. And I'm still stupefied by the fact that we bring on these theoretical aspects in our discussions after these many years of experiencing knee replacement surgery. And we keep on talking about doing more harm and the catabolic status, when I personally now have done tens of thousands. and in the same manner, and we don't see any serious issue. And I qualified my statement when I say that after the first surgery, if the metabolic status as indicated by all reports, clinical examination and laboratory reports indicate that the body is stable, then I would go and finish it off if the patient was willing. So, gentlemen, let's zoom out and understand where and how and why we put forth our arguments and things. And I say that each one of us has a right to our own philosophy of approaching our practice, but the larger audience should go away understanding the overall movement, the push which brings these sort of debates, discussions, and movements into the practice patterns. You know.
So this is what was done. It was done in a 5 days gap.
There you go.
As the discussion, now we have again the house divided into two sections. So bilateral single stage, yes, in this age group, definitely not advisable. That was the point I wanted to raise out of this question. And the second point is, I knew that the staggered thing will always raise a lot of discussions. But as Dr. Bharat sir said, we also in our center, I routinely do a lot of staggered knees. And I know that literature doesn't support in a big way that a lot of complications happen. But as it was discussed, I normally plan for the other side after 5 days or 1 week. If the patient's general condition allows me to do, then I go ahead and do a second stage. But that for that, there is no definitive points to say, okay, these cases can be done or these cases should not be done. So it is all during the admission, how the patient recovery is, how physiologically she is able to do the rehabilitation part, and how the metabolic status and the hemoglobin. If the hemoglobin is falling rapidly and the sugars are going up, then it is not a correct candidate. We can discharge them. Otherwise, it saves a lot of time, money, and also patient's readmission and everything all together. In Indian scenario, I think staggered is also plays a very good role. So that was the point. For that point I raised. I know there are lot of surgeons who are trained outside India. They don't practice the staggered, but still the staggered in India definitely plays a good role. And particularly for old age, because they don't have a lot of people to come again and again and stay with them. So I think that also has a role. That was the point I wanted to raise.
I would just like to
Can I quickly add a point here?
Yeah, quick point.
Yeah, in fact, when we talk about data, there was recently, it was presented from New Zealand. They've got their national data pooled of about 5,000 joints, where they have compared single day to and cases, just retrospective comparison, where cases were staggered between 5 and 7 days. And interestingly, their data, I think this is Mahoney, I'm not sure, it was presented at a zonal Asia Pacific conference on a panel where the data is actually better in terms of complications for these staggered ones out. And they themselves were gobsmacked as to how it was. But, I myself, I am not a person for doing this 5 to 7 days apart, but the data actually in only one place in the world says otherwise.
Okay, thank you.
We don't have any other data to compare this, but that's interesting to note.
Thank you.
So somewhere we must be doing it right.
Okay.
With our gut feelings.
So we'll go to the next case. Again, it's a 7. See, most of my cases here, what I'm going to show is all 70 years above, considering the old age and the geriatric meeting today. So 75-year-old female. This is how the patient is obese, severe varus, bone loss, osteoporotic. And this is the patient's walking video, very difficult, typical Indian varus, obese female, old age. So these are the stress views here available, both sides, right side and the left side stress views. So this patient, the blood investigation, slightly different from the other patients, what we discussed till now. Sugars are a little bit on the higher side. Hemoglobin again is 10. Vitamin D is low, BMI is 37. So in this case, old age, osteoporosis, obesity, severe varus, bone loss, diabetes, hypertension. So patient is medically on the comorbids are high, obesity, varus. So how are we going to approach? Dr. Kirti Shah, in this patient, when it comes to the clinic, will you say, okay, go and control your diabetes, or will you investigate for the osteoporosis and do the weight management and then plan for the ticket? Because we know this patient needs a total knee. So a quick points regarding these things?
Rajkumar, I think Kirti has just gone for a couple of minutes.
Okay,
so-
Dr. Yogesh, please.
There are times where I would like to say it, but it may not be practically possible. So
in
I
this
would
case,
probably,
we will,
yeah,
we will stick on to this case.
Yeah, weight management, no. Osteoporosis treatment, post-operative for me. Diabetic control, I've tried to say, go back and manage your diabetes, but they come back 1 month later with the same problem. So I just tell them the importance of the diabetes, give them the consent, them with the increased risk of uncontrolled diabetes post-op, and do it, but definitely one at a time in this case.
Okay, Dr. Neeraj?
So diabetic control, yes. Osteoporosis, nothing.
No. So in this diabetic control means you say, okay, you go back, control your diabetes, and then come back for this sugar level 190 and 8.3 of HbA1c. So the point is whether you will send them back or you will plan the surgery.
So I will send them back. And I will explain them, as Yogesh rightly said, that at this sugar level, it is not desirable. And if the patient comes to me after 1 month with the same level, then it gives me an edge that now probably I can explain that I will keep your sugar under control less than 200 for the period while you are admission and afterwards, and will definitely go ahead with the surgery. For osteoporosis and weight management, nothing is special.
Okay, right. Dr. Shrikant?
Yeah, nothing particular about weight management. As far as diabetic control is concerned, I've got a fantastic patient. He's very aggressive. So he not only controls pre-op, but also during intra-op period. So as long as he's happy, I'll go ahead with that. And if I'm worried, I might use things like Stimulan. Even in primary settings, I've used that. And osteoporosis management, I do for all the patients pre-op. So I know Yogesh mentioned NICE guidelines doesn't support it, but we are in India, we are not in UK. So I still go ahead with the osteoporosis management pre-op.
Okay, Dr. Bharat sir.
I would have a word with the physician and the patient. If they have been in reasonable active mode in terms of trying to control her diabetic status, and despite that, those efforts, if she has been maintaining an average of 190, which is indicated by 8.3 HbA1c, then I would accept it as being the status that she is going to have. That's the nature of the beast as far as she's concerned, her body is concerned. And then I would go ahead, keep a sliding scale insulin as my method of control in the perioperative period. Go ahead and do the replacement surgery, and then put her on anti-osteoporotic treatment, either in the form of denosumab and so many teriparatide or so many other options that we have now. And the weight control, I wouldn't worry, because in this particular case, you didn't mention the BMI or the net weight. You just
it is 37, sir, BMI.
How much?
37, it's here.
Yeah, so good. So at her age, and if we make her active enough, and the catabolic status that we will trigger off with the surgical act, etc., and then just counseling her should be good enough. I won't do anything more than that as far as weight control is concerned.
Very good, very good. So that is the point I actually wanted to bring out of this case, because this is almost like a routine blood initiation we see nowadays across, like sugars around 190, 200, HbA1c 8.3, 8.5. So in these kind of cases, obese patient, severe whereas sedentary lifestyle patient, it is very difficult to ask them to go and control the sugar again and bring it to 7 or 6 and then plan for the surgery. In fact, if we do the surgery, make the patient walk in this old age group, that will itself will help us to bring back the diabetic control. Rather than trying to send them back, in fact, it will worsen the situation rather than improve the situation. If it is like somewhere around 11 HbA1c, 300, 350 high sugars, then we can say. So in this kind of cases, I think the aggressive management of totally replacement, people might say, no, why you want to jump in? No, this is the patient where you need to do the totally and make them mobile as early as possible. So that was the one I wanted to bring it. And again, regarding staggered or staged, yes, we have discussed that. In these kind of cases, in these kind of very obese patients, diabetic patient, comorbids are high. These cases, yes, staggered, we have to take a call after the first knee. We should not think, yes, we will do a staggered. After the first knee, we can take a call depending upon the other factors. Okay, coming to the bone loss management in this case, any additional things you would like to add upon? Dr. Kirti Shah? Is he there? Okay, he's not there. Yes, Dr. Bharath.
No, nothing. Sorry, I was indicating to my sister, don't make a noise. Because I was
Okay. It's okay, sir. You can continue if you like.
Okay,
regarding
so
the bone loss.
The bone loss that I see here is not something that would make me worried too much. At the most, I would use simple measures such as either the femoral condylar piece to fill in the tibial defect with a bone graft or with cement and screws. But I certainly don't see any need to anticipate the need to use wedges, or augments or anything of those types.
Okay. Anybody like to add upon, Dr. Yogesh?
I would certainly use a stem on this case because obese, osteoporotic, diabetic, so higher chances of problems. I would definitely not do bone grafting because of the diabetes and other things, so less chance of incorporation of bone graft. But most of these cases come very well with just cement, just a stem for additional support. That's it, to prevent sinking. Very rarely the defect is large, then directly I'd go for a wedge rather than doing bone graft.
Yeah, okay. Dr. Srikanth, any additional points you would like to add, or?
Yeah, I mean the same really what Dr. Bharath mentioned. So cemented screws, and if I need to use a bone graft or a wedge, definitely I'll stem it.
Okay, right. So this is what was done for this case. The right side, yes, as Dr. Yogesh pointed out, right side, in spite of the stress views, I was not able to exactly come out of the bone loss situation in preoperatively, but perioperatively there was quite a big bone loss. Considering the obesity and osteoporotic nature, I stemmed a small cemented stem I added additional to the screws. On the left side, there was not much of a bone loss, only as Dr. Bharath Modi sir said about the screw augmentation and cement, which I routinely do if the defect is minimal. So left side I didn't use a stem, and right side I used a stem because considering all the other factors. So the next case, 77-year-old female, rheumatoid. Left side is again bone loss, valgus deformity, and this is the right side X-ray showing again a minimal valgus. So this is a long leg film. Yes, Dr. Kirti Shah. Is he there? No. Okay. Dr. Neeraj.
Yeah. So now if the blood parameters and everything.
Yeah, medically this patient is fit for surgery.
Okay. So in this patient, I will first get a varus stress view just to see that how much I am able to correct the you have get it. So now you see that you have been able to correct it nicely, and still some varus is there. I will go for a total knee with a stem, depending after taking my tibial cut. If the gap is more, then cement with a screw and stem will be my answer for this knee.
Okay. Dr. Srikanth.
Yeah, she's rheumatoid, so I will not forget about the proximal joint, which is hip. It looked little arthritic in the X-ray, but I'm not sure about that. But if there is no arthritis in the hip, I will plan for a total knee and keep the stems and probably go for a PS knee as well.
Okay, Dr. Yogesh.
I would keep a low threshold for constraint, so femoral stem as well in this case. Rheumatoid, so poor ligaments, osteoporotic, and old. So I would keep constraint standby, and unless I'm really satisfied with how stem for sure for the tibia, there's no doubt. But I think the defect can be managed very well with cement itself, the tibial defect, just with a stem at that age. But maybe looking at that valgus stress view, I would have a very low threshold for a constraint. They would tend to be unstable post-op.
Yeah. Anything more to add?
Tend to be very, very attenuated.
Dr. Kirti has joined.
Oh, okay. Okay, right.
Sorry, I had to leave. Interesting case. It's quite a deformed knee joint. But yes, what you have done is the varus stress view gives you lots of information. probably you can, in this case, definitely a stemmed tibia, maybe a stemmed femur. Maybe consider putting a constrained knee if the ligament instability persists.
Can you quickly say, you said about the stemmed femur, why was that you raised that point? Any specific
because when you start doing the distal femoral cuts, you'll find that the medullary canal of the femur is very wide. Your bone purchase, the cement bone interface may not be brilliant. There is a high risk that this component may fail. It's better to have a stemmed femur at the same time, a stemmed tibia.
Dr. Bharat, sir?
I would keep the equipment ready for a highly constrained, basically a TC3 set on the standby, and use whichever bits and bobs that I find necessary on table. For example, I would certainly already, before even starting surgery, I know that I would be putting a stem in the tibia. I might use an augment on the tibial side. I might end up using the same sort of a augment and a stem on the femur side. Even if I don't use an augment on the femur side, but if I have to use, for example, a highly constrained like TC3 articulation, then just to ensure that the overall reconstruction doesn't go into loosening, and then I would add a stem because of that, rather than because of any augment, etc. Okay. So this is a sort of case where any of us who have done enough would be alert to the need of using component more than what one expected, and therefore you keep everything ready and use whatever is necessary.
That's the point. Yes, correct. So the whole idea of putting this case is again old age, rheumatoid, osteoporotic bone. Yes, all the points which we discussed in the earlier cases are there here. The additional thing is, the next important point for the delegates is definitely in these kind of cases, it might look as if it is a very severe valgus knee, but a stress view is a must here in these kind of situations where we will know whether the deformity is correctable or not. The second point is how much of bone loss is there and whether the bone loss is contained or not. All those points preoperatively, and based on those points, we have to be prepared. Starting from a PS knee to a semi-constrained to a constrained knee, we should have all the armamentarium with our in our theater, and then based on the need that arises at the time of the surgery, should be able to decide what we want to use. So it differs from patient to patient, case to case. So again, all these points was discussed. So the implant choice again. So in this case, how I managed after taking the cuts, if you look at this case, already preoperatively, the stress view showed that it is a correctable. So not much of release needed in this case. But if you look at the bone, after taking in the cuts, initial cuts, it was like a contained defect. Very, very common in a tibial valgus knee, a contained defect on the tibial side. So in this, for this, what I did was, I went ahead, made multiple drill holes, the sclerotic bones was curated, and then this kind of preparation was done, and then augmented with screws, and then cemented, and this is what the post-operative X-ray. So in this case, the patient was very, very thin, and very, very, because of the rheumatoid and a very thin, not much of obesity. So because of that, I didn't go for a stem here. And the right side didn't need any augmentation, just with the management of proper soft tissue balancing and implant placement, I was able to get away with a regular PS knee. So this is a post-operative X-ray.
Dr. Rajkumar.
Yes.
We just need to stop in few minutes, couple of minutes.
Is it? Another 15 minutes is there, it shows?
No, but we continue for one more case, but we started very late. So it's already 8:30 for the next session. That was the reason. So,
okay.
Yeah. So you can take another case and then probably, this can be the one more case we can go.
Okay, this case, this is a one, just I'll show one more quick case.
Yeah.
Okay, this is 79-year-old female, osteoporotic patient. Patient came with a lot of pain and deformity for a long time, but patient came to me with not this one, sorry. This one. Patient came to me with a lot of pain and severe pain in the proximal tibia. So hemoglobin was very low in this patient. Okay. Patient has a acute stress fracture. So this patient, severe osteoporotic deformity for a long time and acute stress fracture 1 week before, came to me in this situation. So from the panelists, any one like how to address the stress fracture here? Yes, Dr. Kirti. Dr. Bharat, yes, sir.
Yeah, I would do long stem,
Okay.
and, uncemented long stem tibia and get on with it.
Okay. Dr. Yogesh?
Yes, I agree with Dr. Modi. I would do that all in one stage.
Okay, right. So that is what was done here. Same uncemented tibia, stress fractures, they do very well, uncemented in a single stage. So opposite side was done after 2 months because of the patient's severe hemoglobin loss and then multiple transfusions. Just like this couple of cases I had. One quick last case, want of time, shortage of time, severe valgus, again osteoporotic bone loss, again one more stress fracture. So this is the case. Yes, Dr. Shrikant, quick last answer.
Yeah, I mean, so how was it kind of a global instability, or what was the thing with the knee?
No, knees severe osteoporotic, arthritic bone loss, valgus deformity with acute stress fracture. So you would like to address the stress fracture here or the knee?
I mean, you do a knee replacement with a long stem. So just as the last case here.
Okay, Dr. Kirti.
Yeah, I think I will have to address both. The stress fracture is because of the deformity in the knee joint. So you can't just individually fix the stress fracture.
What system you would like to use?
Stemmed tibia, long stem, probably uncemented stem. Yeah.
Okay. Okay, this case again was, I used a hinged system because of the severe osteoporosis, and the bone loss was very much vertical posteriorly, and the valgus also was not fully correctable. It was only a partially correctable valgus. So to address everything, I had to use a hinged system with a long stem tibia, and this is the post-operative X-ray. Thank you.
I cemented the femur there?
Yeah, femur is cemented.
Why did you cement the stem?
It is very, very osteoporotic. In the femur, it is, in fact, these kind of very osteoporotic nature, and also I'm using a hinged system. So in these kind of cases, the stemmed femur gives a better result rather than an uncemented femur. In tibia, because of the stress fracture, because of the acute fracture, I used an uncemented, but I tried to get the correct fit, rotational stability. If there is no rotational stability is there, then I would like to augment it with the small plate in the tibia. But otherwise, if the stability is good, I no need to use a plate.
Yeah, Dr. Rajkumar.
Yeah, stopping.
Yeah, thank you very much. All the panelists.
Last point, Dr. Amar made a point in the chat box. What about medical legal? I organized a lot of medical legal meets in India, particularly with the top Karnataka High Court lawyers and also Supreme Court lawyers. The average litigation now in India is around 5 crores per case. So I think that angle should be kept in mind as well. So because Dr. Modi rightly mentioned what happens in US is, the local practice, and sometimes we have the same influence. So that legal aspect should be kept in mind as well. That's all. Thank you.
Thank you, everyone. Bye.
Thank you, Dr. Rajkumar, and all the panelists, Dr. Bharat Modi, Dr. Shrikant, Dr. Neeraj, Dr. Kirti, and Yogesh Kamath. Excellent session. Sorry, we probably had to reduce about 10 minutes because of the delay, but the next session is already on. And we don't want to delay longer than that. So I thank all the panelists, especially Bharat and Dr. Rajkumar for moderating this session. Excellent discussion. And we move on to the next session where we have first time included shoulder into this geriatric part, which is also a very important subject. We have again the illustrious panel. Dr. Ashish Babulkar is going to moderate the session with panelists Dr. Kalpesh Trivedi, sports medicine specialist from Ahmedabad, Dr. Raman Agrawal from Delhi, Dr. Nagraj Shetty from Mumbai, Dr. Harpal Singh Sahli from Ludhiana, and Karthik Selvaraj from Coimbatore. So pan across India, we have got the specialist sports medicine arthroscopic surgeons with Ashish Babulkar as a moderator. So I request Dr. Ashish to share the screen and start the ball rolling.
Thank you. Thank you very much, sir. And really appreciate the efforts of DEEPAK Dave and team for organizing GOSICON so consistently every year. And this is actually the second time we are part of GOSICON. And I hope we can make some contribution to GOSICON. It is an unusual speciality for most of the GOSICON members. And I welcome all my panelists, including Kalpesh, who has been organizing on behalf of DEEPAK Dave, and Raman Khan, Nagraj, Harpal, and I hope Karthik has joined us. Yes, I see them all here. Excellent. Without much ado, I think, friends, we should continue. The theme of this meeting is oldies and goldies. Some of us you'll acknowledge are oldies. The rest, there are a couple of youngsters here. Unfortunately, they get clubbed with us. So we'll call them the goldies. I have, being a general audience, I think rather than keep it into a specialty, rotator cuff and advanced, I've kept 3 or 4 cases. We'll see how time goes by. And we'll start with trauma because that's the flavor of the month usually for GOSICON. This is not so elderly, 55-year-old lady, and she had a typical proximal humerus fracture. And she was treated elsewhere outside Pune. And she presented to us 3 years later. This was her first X-ray, and that looks like a classic fracture dislocation, challenging one. I'm going to make this easy for my panelists because I'll take you through so that we can devote more time to the other cases as well. And her local trauma surgeon ended up doing this, and in a post-op X-ray, you can see the staples are still there. Everything seemed to have fallen apart, and we wonder why this happened. So we will debate a little bit on this. For each of my cases, I'm going to pick on some faculty to make a gist of what were their do's and don'ts. So we'll start with Nagraj for the first case, and then we'll proceed forward. So Nagraj, I'm giving you lead time so that you can jot down points, so that after we've done the case, you'll be able to summarize some nice take-home pearls for everybody. And then the surgeon realized, and then he took another opinion from his colleague, and colleague told him and convinced him that, no, this is not right. We need to revise this. We're not going to fix this. And quite rightly, he went in and did a local form of strange looking hemiarthroplasty. And so we'll take it from here. Raman, you are the champion arthroplasty surgeon from north of India. So please guide us with this lady.
Okay, now at 55, the first mistake was not getting the reduction right and not holding on to the reduction. There are two separate things, getting the reduction right and holding on to the reduction. But only AP view available, so I can't comment much on the immediate post-op X-ray. As far as the decision to go for hemiarthroplasty and sacrifice a reasonably well-looking head with metaphyseal component along with it, I think that was a mistake. At 55, and it's a trauma situation where tuberosities are good, we should have fixed it nicely. But anyway, that's past. Looking at the hemiarthroplasty now, it's really strange looking. I can see some holes for the tuberosities, but I really don't know where the fin is sitting. Although the height of the prosthesis looks okay and the version is really bad, it is posteriorly subluxating. Of course, I don't expect much function with this. The next X-ray, Ashish.
So we agree, and I think Raman, you're right that the original fracture was doable. Even if it had failed, we should have revised it. Kalpesh, would you like to add to what Raman is suggesting?
Yeah, actually, dislocation was missed, or what was the head is still out in post-op?
Yeah, so why would that happen? I mean, it's quite obvious that there's a dislocation here. And why would a surgeon who's orthopedic go in and fix a plate very nicely and miss out on the head?
Very strange, actually. It's quite obvious on plain X-ray also.
Correct, correct. Absolutely. So intraop imaging has been seriously suspect here. And sometimes some trigger-happy surgeons might... Harpalji?
It seems he's done a OIF rather than the ORIF. The dislocation part, the head is exactly at the same place where it was operatively. He's totally, I can't comment what difficulties he faced intraop. Probably the part of the head that's lying at the back, he's taken it as a full part of the head and thought that the rest of it is crushed. Totally missed out on the dislocation. And second, I would like the opinion of the house. Would you take such a patient at 55 years of age without a CT scan into the OR?
That's a very, very good point. I'm glad you brought that in. So very few of us treat this as an intra-articular fracture, and any intra-articular fracture in the body would mandate a CT scan, and that would actually have given him a much better pre-op planning. Nagaraj, do you think perhaps he went in as a deltoid split and then missed out because that was a limited approach? So that can sometimes throw you off.
With the dislocation so evident, I don't think a good orthopedic surgeon would go by deltoid split, because reduction is the key here. We know the axillary, the neurovascular bundle is right there. So the deltopectoral approach itself sends us into anxiety. So the deltoid split is unlikely. I think probably what would have happened in his case is he would have tried some reduction, got a partial reduction, felt that he's fixed some part of the head, and it has just given away immediate post-op. Probably the intraoperative imaging, which I'm sure we will discuss, is critical to make sure that you leave the OR being 100% sure in all the planes, not just in one plane.
Correct, correct. Absolutely. I take your point, and that's very important. Now let's for a minute go back that this was a fresh patient, Raman. And in terms of guiding our colleagues on how to approach this as a shoulder surgeon, what is the pre-op planning that you would entail, and what are the requirements during surgery? Some tips.
Yeah, so as Harpal said, any proximal humerus fracture or fracture dislocation or glenoid fracture, it mandates a CT scan, because you need to look at the fracture from different angles, especially from the top and from the side, so that you know the relation of the fragments to the glenoid. Besides the CT, I would also want a CT angiogram in this case, because I would want to know where my brachial vessels are lying, and
even if your radial artery was good?
Well, even if the radial artery is good, the late kind of pseudoaneurysms are common, so there is no harm. Once you're ordering a CT scan, you should order a CT angiogram in this case.
Okay, now in terms of Kalpesh, reducing this head, that head's trapped under the coracoid, and once you go in, the planes are going to be all mixed up. It won't be like your conventional proximal humerus fracture. So what are your tips for reducing the head?
So basically, any pointed spikes or any pointed sharp instrument should be avoided, because the head is exactly sitting on the neurovascular bundle. Second important thing is we have to reduce the tension on the subscapularis, so that you can go in the subscapularis recess, gradually manipulate the fragment and reduce the head using a small shunt spin or some K-wire. In such, whenever you find this metaphyseal spike, it is mandatory that the spike should not damage the vascular structure, because the vessels are very, very important. And second important thing I would like to make on CT scan, many times with this dislocation, you have a glenoid rim fractures also.
Yes.
So it is mandatory to look for this particularly rim fracture, and whenever you find it, better equipped with the suture anchors or some small fragments.
Yes. So let me just modify what Kalpesh said. He's brought up some brilliant points. is do a subtracted CT scan, so that then, because if the head is covering the glenoid, one will not be able to assess the glenoid, and a rim fracture is not unusual. And if you're there, you can fix it. My biggest worry is when you go in, the subscap is not there. The subscap has gone and turned inside with the head fragment. So identifying the fragment and the subscapent planes are difficult, but sometimes you get the distal end of the proximal fragment, which is jagged, and you've got a calcar there on the head. You can use an Alice or a Cocker to hold that bone piece. So you be sure you're catching bone, and then reduce this with simultaneous skin pressure on the medial side to reduce this. In an acute situation, I don't think there's a big challenge. In the chronic situation, it is a very big challenge, and it is not going to reduce just by cajoling that head out of that coracoid. So in those situations, I always keep the option of a coracoid osteotomy. I don't need to use it in an acute situation, but if you're struggling for exposure, just don't hesitate. Take the tip of the coracoid off, peel the pec minor and conjoint down, and then lo and behold, everything is right there. So let's move on. So what went wrong? I think he's just missed out the principles of ORIF. A fracture dislocation is a much different animal. And finally, when he's done his hemiarthroplasty, he's just not addressed the greater tuberosity, because that is the key in the proximal humerus fracture. If you can get the greater tuberosity in position. And Raman alluded to this. The version is a massive challenge, and he's just messed it up here. So Harpal, can we talk about version? In an elective case on a replacement, it's going to be fairly easy because all the 4 anatomical landmarks are right there. But in a fracture situation, everything is exploded. So what are the guidelines?
Yeah, so I faced a similar situation, you know. One of my colleagues outside of our institute was doing this kind of a fracture, and while reducing the head, he ended up injuring the major vessel. So tackling the bleeding, they sent the patient with a pack on. The plastic surgeon tried, couldn't do it. So I called in my cardiothoracic colleagues. They did the repair. Once they did it, they told me, you know, you go ahead and fix whatever you want. And when I tried, it was middle of the night and the reduction wasn't coming. There was something wrong. And then we realized the head wasn't inside the body. What looked like a head was not actually the head, was just a rim of a cartilage. And then the next morning, that surgeon calls me up, boss, head to mere table pe hi reh gaya, side trolley pe. So in such a situation, that's what I learned. You know, the version is you put your elbow at forearm at 90 degrees flexion, and I would externally rotate the forearm to look at my version and then operate. It's always that the my assistant would be holding the arm externally rotated by about 20 degrees, and that will give me the position. And every time you bring it back into with the hand pointing forwards, again take it to external rotation, and that's how I play with the version of the femoral humerus component. If you do it another way, just share your views, you know.
Lovely. Raman, I'm sure you have something to add here.
Well, in a trauma situation, it's a little bit difficult because the proximal portion of the biceps groove is gone. But if you can palpate the biceps groove, see, remember the biceps is the most lateral structure when the arm is held in neutral rotation. But bicipital groove overestimates by 10 degrees of internal rotation. So just keeping that in mind, if you just play with around 20 degrees of retroversion with bicipital groove, the anterior fin of the prosthesis should sit aligned with the lateral edge of the bicipital groove. And then bicipital groove, you must know the anatomy of the bicipital groove. So the bicipital groove actually externally rotates, and it is ascending on the shaft like this, and then it suddenly goes laterally, and the lateral lip of the bicipital groove is the most lateral structure with the arm in neutral rotation. And when I keep the arm in the neutral rotation, it is the lateral most structure. And keeping that in mind, I rotate my fin, the anterior fin, to the lateral lip of the bicipital groove. Of course, there are many other things Like elbow is around 20 degrees, the condyle is around 20 degrees retroversion, and then you add 10 degrees more for the play of the cubitus valgus angle, and then you get around 30 degrees of combined total retroversion. You go beyond 30 degrees, it is going to subluxate posteriorly. So these are the usual things. In a trauma situation, what you can do is you can palpate. You know where your biceps is. You can palpate and then come. Second thing is shield fragment is usually available. In this case, it's not available. I mean, I don't have the CT scan, but the case Ashish is showing, you can also mark the landmark with an electrocautery on your humeral shaft and keeping that landmark always in mind. This is what I use for the version mostly. What do you do anything different, Ashish?
Personally, I think we've done a lot of studies. We've published on the native anatomical version, and we find a lot of variation between native anatomical version between all of us. And so I don't use a fixed 20-degree guide. So I try to use a native version, and sometimes it varies from 0 degrees to 50 degrees. So that's the variation on a published article in the International Journal of Anatomy. So number one, I rely on the medial epicondyle. The head and the medial epicondyle always look at in the same direction. Number two, if you look at the coracoid is never a round circle. There is always a little bit of spike on the medial side. So where the anterior and posterior cortices meet, there's a subtle prominence there. It's very subtle, but it is always there. And so even if your proximal part is exploded, you can use that. And your medialmost 0-degree landmark of the prosthesis should sit on that coracoid. After having done all this, you still can go wrong because there's no landmark. You bring your tuberosities together. And if they meet in that bicipital groove, then you know you've got it right. And then you know it's stable in 90 degrees abduction or even in wide external rotation. So use several things at your disposal and don't rely on just the one issue. And so you're reinforcing your correct maneuver, because at the end of the day, when you do a post-op CT or post-op X-ray, that will tell you whether you're right or wrong.
Can I just add a point?
Yes, please, Nagar.
So one of the things that I follow in the trauma scenario is a point by Sumant Krishnan, where he says that with the arm by the side, you turn the prosthesis towards the glenoid. Having done this, that usually recreates the normal version of the patient. And I also look at the point that Dr. Raman mentioned, that the fin has to be just behind the posterior border of the longer the biceps groove. So when these two things match, it gives me a fair idea that my version would be acceptable.
Yeah, Nagar, that's exactly what Ashish said, that looking at the condyle and the glenoid,
yeah,
you know, they face each other. So using the condyle will bring the process to the same kind of version.
Yeah.
Collectively, I think we've picked up all these points and we have to use all this. We can't rely on one landmark. So good. So this was the situation. Number one, lateral X-ray was never done. This was the first time she came to us and we got a lateral done. And you can see that the GT is missing and it's floating there posteriorly, kissing that glenoid. So things will never be the same. So this is what we did. This was a third surgery. The gritty prosthesis was completely amiss. So what we've done here is just done a reverse shoulder replacement, which is almost a 2 years delay. We've tried to balance it as much as possible, largely on the deltoid, because there's nothing else here. And this is her 6-month follow-up on the right side. What you see on the left side is her pre-op movement, and on the right side, you will see her post-op. And so these are difficult. This is a third revision. You don't expect magic. You're just telling them this is rescue surgery and you want to pick them up. My biggest challenge is restoring rotations in these patients, because in the absence of greater tuberosity, it's a big challenge. And of course, you have to sit them out and follow them for a long time, because you never know how long this will last. And again, this is not the most optimal way to treating her. So as you see, she's struggling on her external rotation. And I'm afraid, given that it was -30 in the first place, she's come to +25. And we've had a reasonable internal rotation. I think both the patient and the surgeon have been reasonably lucky. Let's move on. This is an interesting article, apart from the number of articles that you have read. This was by Le Martina and from Mark Frankel's group. They picked up 200 X-rays of proximal humerus fractures, all done and dusted, and then showed them to all a panel of elite shoulder surgeons. and ask them to decide just three things. Do you want to do a fixation? Do you want to treat conservatively? Or do you want to replace? And you would expect that an elite surgeons of the American shoulder elbow surgery will have an agreement on exactly what they wish to do. The interesting and most intriguing feature was only 63.5% of X-rays were agreed upon in the first place. What was more interesting on this patient, although in this paper, was that amongst those 63.5% patients who were agreed upon, those were the best results. So there was no controversy there. They were clear cut and dried, and those are the patients. And in the rest of the group, the rest of the 37% patients were all mix and match, and some patients did well, some didn't do well. And you can see when they divided those into two groups of those who agreed and those who didn't, the forward flexion and abduction in the 63.5% group was far, far better than the other group. So I don't think we'll get a consensus, and such complicated fractures will evoke different responses. But Raman alluded, big calcar there with the proximal humerus should have been fixed even in the first instance or even in the second instance. Let's go to another lady. So Nagaraj, do you want to conclude on the first?
Yes, sir.
From your side? Yes.
Rather than the tips, like you just said, just a summarization for the benefit of the audience. So a patient who comes with a fracture dislocation, the first concern that you have is that there is a neurovascular bundle which is sitting right there. I still remember from one of your earlier conferences, Dr. Babulkar had mentioned that on table there was an axillary vein that ruptured and the blood hitting the ceiling. That is always there in the back of my mind when I see these cases now. So I always try to keep a vascular surgeon backup, a CT angiography, whatever possible to make sure that you are doing a safe reduction. That spike is usually sitting on these vessels, so you need to be as gentle as possible. I think all the tips which you need to keep a adequate exposure, whether it is a coracoid osteotomy, whether it is releasing a bit of the coracoacromial ligament, a bit of the pec major, a little bit of release of the conjoint tendon, whatever needs to be done to get a safe reduction, we need to do. Pre-operatively, you need to get a CT scan in all these cases to find out if there is a glenoid rim fracture, subtract the humeral head, and make sure that the glenoid morphology is well understood. Intraoperatively, look at the AP as well as the axial plane. All of us have been taught repeatedly that we need to get the C-arm from the head end of the patient and make sure that you see it in all the planes. Do a dynamic evaluation so you know in the post-operative situation there is no sudden loss of reduction like has probably happened in this case. And if in case there is any problem, and you always usually keep a hemiarthroplasty as a backup for such cases if the head is really split, etc. In which case the three principles which we always talk about, getting the height proper, getting the version proper, and getting the tuberosities well in place, which is not possible with a monoblock. You need to have a nice fracture prosthesis hemiarthroplasty to get some consistent outcomes. So hope I have summarized most of the points.
May I add one thing, sir?
Yes, go on, Kalpesh.
Yeah, so even whenever you want to do a hemiarthroplasty, at least use a platform-based system. That's one point.
Yes, perfect. I think collectively, well done. I couldn't have put it any better. Super. Kalpesh, you'll be the master of ceremony for this, so you can summarize for us for this case. And Harpal, a Ludhiana special for you in the third case. So here you have a 60-year-old lady and no past history. She had a fall from there was a scooter accident, trivial. She fell down. She had this fracture and pain. And she's come to us on the 4th day of her fracture. So, Nagaraj.
Once again, sir, as you have always told us, commenting on one plane X-ray is probably not, we should do this. We should have at least two planes of X-rays, a scapular Y view, or a well-power axillary view to find out what is happening with the tuberosities. A CT scan again, ideally
with this patient because she's in incredible pain and she came from Jalgaon.
Okay.
So we have to work on this.
Okay. So if you tell me that this is not a displaced fracture, this looks like
no, this is not a displaced.
Yes. So the question here is how old is she? How old is she? 59.
60. Yeah.
So the question is obviously whether we can go ahead with a conservative management. So this doesn't look like a classic valgus impacted fracture.
Correct.
Looks like a fracture where it is appearing in alignment. However, it is just likely to fall off. It is looking like an unstable varus fracture. So my inclination in a 60-year-old lady with a 3-part or a 4-part varus inclined fracture would be.
This is Nagaraj, 2-part, no varus.
So if this particular reduction is maintained, if it is 2-part maintained, then of course there is a great role of conservative management with good results. However, I would be very careful with serial X-rays, calling a repeated for follow-up to make sure that this 2-part remains a 2-part, this alignment remains a good alignment.
Yeah, sure. Harpal?
Is there something going on in the proximal humerus? I'm not sure.
I was sure. I was not happy.
Yeah, I'm not happy. There's something going on. I would request my radiology colleague to have a look whether they want to do a CT with the MR or only a CT.
Correct. So we are better at this than radiologists.
Yeah. And, even if I'm managing non-operative, I won't feel shy to take a biopsy, if there is something showing up on MRI. The second thing is, you say it's 2-part, but the head is lower down than you look at the medial side, the shaft and head do not maintain the relation.
Fair enough. If there was nothing going on, I would be reasonably happy. It's an oblique view. It's not the best view.
Yeah.
What could this be if there was something funny there? Raman?
At 59,
have you seen something like this before?
No, really, Ashish. But I mean, I'm leaving aside the pathology separately in the proximal humerus. I'm just wondering two things in this fracture. In the head fragment, I see a double shadow in the calcar region where I'm looking for the Hertel fragment. I see a double shadow. I also see a double shadow posteriorly on the posterior glenoid margin. So these are a couple of things which are bothering me. Is the lesser tuberosity off? And there is no way to judge the lesser tuberosity except for an axial cut. So
no, there's nothing funny there at all. I mean, it's just the texture. Right. The texture.
Okay, but I don't know what's going on there. But this looks like something like a chondral pathology to me. In the chondral pathology.
Yeah. So I would advise at least MRI scan.
At least, okay. Let's give you a CT scan on MRI there. Now?
So definitely this is a pathological fracture.
Correct.
And
so I've had 3 fractures like this before, but it's definitely a chondral problem. So most of the times you've encountered is an enchondroma, which has been lurking previously. No symptoms, no warning signs, and then they have a pathological fracture because that's the weakest part of the bone. And is there, it's fairly innocent. And now you're suspecting the bone quality. So in an enchondroma situation, it's not going to unite because that part's pretty much hollow. It's a cystic lesion, osteolytic lesion. Question is, she's 60 and great pain. How does one proceed? Largely the orientation is good, the position is good. No?
The question here is whether to
biopsy
or we want to take the head off and put a. Is it the question we are thinking about, or?
No. I need help from you, Karthik. So biopsy is one option because we need to know what the hell is going on. So that will be 2 procedures. So do a biopsy, wait for a tedious 6-7 days, and then they give us something vague, and then we decide what to do. Or you could do it one stage, or play wait and watch.
Our radiology colleague will give us quite a good opinion, whether it's something sinister or something just simple like enchondroma.
Looking at the soft tissue around the mass, it doesn't look anything sinister.
Thank you. Thank you.
So then you just open up, take a biopsy and fix it in the same situation.
Exactly. So that was what was going on in my mind, that number one, she's had no comorbidity. She had no past history. She had nothing going on constitutionally, no weight loss, no appetite loss, and no fever. If you look at the MRI, as Karthik very quite correctly pointed out, there is no soft tissue lesion, there's no extension, there is no reaction in the soft tissues. Even the cortical margins are not eroded. Now, So although it looks large in size, it may not be, because the MRI is going to exaggerate the extent and the margin of tumor, because in the presence of a fracture, there's going to be a lot of hematoma and disruption. The cortices are quite thin, but they're quite clean, and the glenoid is of course not involved. The dark stuff here is going to be blood, we know that for sure, and the rest is collection dirty material there, which is cartilaginous, so typical that would seem like an enchondroma. But we need some conviction before I assure this patient that let's do a one stage, because even in the remotest situation, if this was not innocent, what else could it be?
Could be a chondrosarcoma. If it is not enchondroma, then it could be chondrosarcoma. I mean,
Come on, you're right, Karthik, but a chondrosarcoma is going to be massive. I mean, it will be blatant. You would see a lot of destruction there, soft tissue lesion.
Ashish, I will not do a final procedure before having biopsy, because there is a smallest doubt of even metastatic tumor or low-grade chondrosarcoma. It can create really a nightmare situation once you go in without it.
So that's fine. Now we are thinking on chondrosarcoma, you're right, but we are thinking of a low-grade chondrosarcoma. So between an established chondrosarcoma and a low-grade chondrosarcoma, there's a big difference. A low-grade chondrosarcoma is fairly innocent, very predictable result, and does not metastasize. It might be, it might recur locally, but it's very rarely going to metastasize. And often the fine line between enchondroma and low-grade chondrosarcoma is very, very thin. You understand? So once I know this is the case, I would then perhaps trying to optimize the option for the patient, do a PET scan. If it is negative, as in this case, it was negative, then I said we would take an opinion of my onco colleague. So my oncology colleague came up and he had a look at this, and Yogesh said that this fairly looks like a enchondroma. I would go ahead at one stage the way you are planning, and he endorsed that. When two of us endorsed this and the PET scan was negative, in the situation like a trauma, even then it didn't flare up. We were fairly on good ground. We said we'll do a frozen section. If the frozen section shows stuff, then we will have to do a much wider excision for a low-grade chondrosarcoma. And we're not worried about that. But the frozen also came out negative. So we decided that we'll do a bone graft. So we did an iliac crest. We did a fibula. I take only half the fibula. I never take the entire fibula because it's impossible to put the entire fibula in such young ladies. So why waste? So we've kept the other sliver intact. And we measured that we need to straddle the thing for 6 centimeters because it was about 3.5 centimeters in size. That's how we position the patient so that we have access to the complete, we don't have to drape and re-drape everything. So the iliac crest, the lateral fibula, and the deltopectoral approach. And that's the amount of stuff we curated out. So we did a lot of intralesional curettage, which is what I would have done for a low-grade chondrosarcoma anyway. And then we've put in fixed the fibula is inside the split fibula, lots of bone grafting. She's still early days yet, and so we'll wait and watch on what happens to her. She's 3 weeks off, but the tail is, the sting is in the tail. It's not over. The biopsy report came in after 5 days, and it said it appears to be a low-grade chondrosarcoma. So now dilemma, what to be done, because now we can't undo this, or if we have to undo this, it's a massive thing. So again, sat down with Yogesh and we sat down and we decided that although it's a low-grade chondrosarcoma, on the whole, he went to the slides and he says it probably isn't, and it doesn't change the treatment. We've done an intralesional curettage, we've stuffed a lot of bone graft in. The only different thing I would have done if it was known pre-op is I would have put in some cement and stuff. The heat would have helped kill some of the cells on the margin. So I don't know. We'll wait and watch how this happens. If it really is a low-grade chondrosarcoma, it will not unite. And then that itself will give us the answer. But if it's not, then urine will proceed in the next 4 weeks or so. And so difficult. There's no perfect answer for this solution. Kalpesh, can you help us with the summary on this case? Just before you start, I just compiled the list between the enchondroma and low-grade chondrosarcoma. When do you suspect what? So if it's less than 5 centimeters, then it's usually an enchondroma. More than 5, you could suspect a low-grade chondrosarcoma. If there's cortical breach, then 88% chances it's a chondrosarcoma low-grade. If there's a lot of scalloping, which we didn't see in this case, it is likely to be a low-grade chondrosarcoma. And the younger age groups are usually enchondroma. Elderly could be a low-grade chondrosarcoma. Excessive pain and bone scan, again, irrelevant in a fracture scenario, may point towards a low-grade chondrosarcoma. Kalpesh, all yours.
Before Kalpesh, please, can I ask you one question, Ashish?
Yes, please.
Had you known this is a low-grade chondrosarcoma, would you go for maybe a couple of centimeters more resection on the distal limit and choose a reverse prosthesis straight away?
I was planning a hemi because she's just 60. And in a low-grade chondrosarcoma, you don't need to go 2 centimeters down because it's a very low aggressive tumor. If it recurs locally. So, but for a curettage, I would have used bone cement because phenol and such stuff will mar healing of the tuberosity. We want the tuberosity coming in there. So I would have done a hemi rather than a reverse. Yes. Yes, Kalpesh.
So whenever we find proximal humerus fractures or shoulder fractures with a low intensity trauma, always a very high index of suspicion of a pathological fracture should be kept in mind, and better to investigate in form of CT scan with MRI scans to know the soft tissue involvements also. And it is always advisable to get the biopsy first, either a needle biopsy or a standard biopsy, keeping the future incision in mind to avoid a disastrous situation in case of such incidents.
Indeed. So those PET scan features, pre-op workup, oncologically, not only because he brings in a lot of expertise, but they often look at the X-ray and they can tell us, and then they actually go in and see the histopath slides. They understand histopath, we don't. And of course, medical legally it covers you as well. So it's nice to hunt in pairs in such cases. Right. Harpal, this is for you. So you're going to summarize this case for us at the end. So your time starts now. This is 69 years old, a gentleman, diabetic for dog's years. He had a fall 18 months back in his palm, usual routine fall. He had a shoulder injury, presented as a frozen shoulder, was conserved for a long time. And then he sent me his MRIs on WhatsApp or email, I think, last year. No, April, around that time. And I looked at it and he had a very large rotator cuff tear, supraspinatus subscapularis, and I recommended that he undergo an arthroscopic cuff repair. And he was not willing. And his colleague who was dealing with me, and he was the intermediary, told him, Dr. Saab, ye bilkul taiyar nahi hai, ye stem cell treatment lena chahta hai. So I didn't remember this, but he came back this time and told me in November that I recommended that he should have arthroscopy, but if he is keen to have stem cell, let him do it, no harm, he will come back. It is not going to work. He took stem cell treatment from a US physician, and I wish I could name and shame him, but I don't have his name. And this gentleman from Hyderabad, who's a senior physician, went in and gave him 3 doses of stem cells over 3 different timelines and said that everything will get better. Our gentleman went up. I have a lot of audience here. So this gentleman went in and told him that Dr. Babulkar is not keen on conservative treatment. His reply he got from the stem cell therapist was that this is routine. They are my competitors. So they don't like. Can you have somebody mute? Can the admin mute the others?
Hello? John, can please mute, please.
Yeah. So his suggestion was that orthopedic surgeons don't agree because they don't like whatever. So what happened was.
Can you unmute? Mute John, please.
Yeah. So finally, he just deteriorated, and then this November he came back to us, And that was when he presented with this situation. And you can see the left side. He had severe disability and severe pain on his left shoulder, almost like a pseudo paralysis on the left side. He was in great disability, great pain. What had happened was early November, when he was at his factory for some inauguration, he couldn't get up from the sitting position. His assistant went and picked him up in the axilla. And when he did that, he heard a noise and he had a dislocation. So he pretty much subluxed there because of that large, massive cuff tear. So you've got a fair idea now. He has a very poor range of movement and a lot of pain. These were his April MRIs. So we are looking at the previous MRIs, pretty large tear, and you can see a significant tear there. And subscap also is involved. There's a mild fluid, there. And this is the dislocation X-ray post that first week November episode, which just took him off his feet. And after that, he was miserable, and then he decided to come over. So Karthik, I'm going to ask you to comment on this, because these were his MRIs when he came here, and these were local MRIs done by us here.
That's the MRI picture shows a dislocated head. It's a very unstable situation, yes. And I guess there is no tumor or anything there, sir. It's the gray shadow is all blood, and it's just collected hematoma.
Yes, trust me, there is no tumor here. Nothing. It's all, you see what you get.
So I'm not seeing any T1 sag of this MRI.
It'll come through. Once you're done this, I'll give it to you in the next.
Yeah. So it's a unstable shoulder with a massive cuff tear. It almost looks irreparable to me from whatever I've seen, but I need to see the quality of the muscle.
There you go. Here you go.
There you go. So you can now see the T1 sag, which shows completely atrophied supraspinatus, infraspinatus, and subscapularis. There is almost no muscle left. There is fatty infiltration and atrophy as well. So the answer here is quite straightforward. In a person with unstable shoulder, massive irreparable cuff tear, the solution which is the best for him would be a reverse shoulder replacement.
Right. You are right. We are heading towards a reverse, but there are a lot of question marks here, Karthik. Number one, what's going to hold it together? There's extensive fatty replacement. I've seen a lot of late patients come in fatty replacement. This is profound. I mean, there is absolutely no muscle there left. It's just converted in fat.
His deltoid is okay, sir. His deltoid looks all right.
Well, clinically, it's difficult to examine him because he's dislocated, but posterior deltoid is firing. We knew that for sure. The anterior and lateral was difficult to examine. But even here on the MRI, it's pretty thin.
It is. In the previous cut, we can see that in the previous section,
here it was good, but this was April.
The next, no sir, just go back. Next one. Here again, you can see the top part of the deltoid is actually off.
It's off. It's just not good. Not good.
Neuropathic.
So we thought it was neuropathic, and we went through all that, and there's nothing wrong. His cervical spine is clean. There are minor OA changes which are commensurate to his age. My biggest worry was stability. Is that process going to be stable? Now, Raman, let's have you come in. What do you anticipate? This fellow has been dislocated for about 4 weeks now, or 3 weeks.
Yeah, I mean, considering we need to just make sure the integrity of the deltoid is immaculate. There cannot be any compromise in the deltoid. Yes. And as you are seeing, the deltoid is thinned out on the axial cuffs and in the further sagittal cuffs as well. So yeah, so once you said that anterior middle deltoid, I personally think, I mean, I know that some people who have done some reverse shoulder only with the posterior deltoid. I'm not that brave. I would need at least middle and posterior both. So if I'm not sure of the middle deltoid, either because of its functional incompetence or because of its structural incompetence, and as you showed in the coronal cut, that the superior part of the deltoid It's actually, there is no muscle. It's all white signal, no the coronal cut. The coronal cut.
What is the option then?
I think just reconstruction of the deltoid first, that's paramount, because without deltoid and the cuff gone, he doesn't have anything.
The NCV, did you get an NCV done for the deltoid, sir? Is the axillary nerve intact?
No. But we did a ultrasound and all the fibers were firing. They were thin, but they were firing. Posterior deltoid is good, healthy. So we were based on the premise that he doesn't need.
This deltoid looks off.
But it is not off. It looks ill. It looks fatty infiltrated.
Yeah,
it's not off.
Maybe it hasn't fired for quite some time. So
yes.
You mean a diffuse atrophy kind of a situation?
Correct. But what this is open to all the panel. What is it that in 9 months or 1 year has made this? I've never seen such profound fatty infiltration where masses of the deltoid are completely substituted.
I agree, and usually the teres minor is spare.
Yeah.
In this case, the teres minor is not spare, and deltoid is not spare. So my apprehension and rather suspicion highly points to an axillary nerve injury, because teres minor is developing fatty infiltration, deltoid is developing fatty infiltration. If the axillary nerve at fault, even if the EMG, even if the NCV is okay, we need to find some person who does a good NCV.
Raman,
I've got one in Delhi now.
Our neurologist team is top class, but there is no axillary nerve happening because sensations are good. Posterior deltoid is firing very strongly. So without posterior deltoid, I have no suspicion that. Kalpesh, you want to chip in?
Kalpesh, looking to the huge amount of the bursitis, rheumatoid arthritis or rheumatoid.
Yes, Kalpesh, I noticed that. Yes.
Monoarticular at 69. This is not how this is Milwaukee. All the debris that you see there is classic cuff tear arthropathy. There's a huge amount of collection here. This is Milwaukee. So these are cartilaginous granules, which are not unusual in the cuff tear arthropathy, which has been undergoing a lot of physio as such. What I wanted to make a point here, we are just in the last 8 minutes, that's why I decided to speed on. It was very important to do the CT because that head has been sitting on that soft glenoid for a good part of a year. And so that has softened and deformed that glenoid. So that's why it was absolutely mandatory to do a subtracted 3D imaging. And then now I have a glenoid which is flat up here on the posterior half, which means only 12.5 mm. And the rest of the 12.5 is sloping facing anteriorly. So you have an L-shaped glenoid here, and that's a major challenge. Apart from the fact that there's no soft tissue support, we have a very awkward upside down glenoid here. And that's what's been happening here. And if you look here, that's the Friedman close to almost 19 degrees. Such.
Yeah.
And it's medialized. The vault is gone in, if you remember.
Yeah.
So there's very little space for me to run and dream and medialize this any further because all that entire glenoid that was here has been eaten up.
You need a graft from there.
So graft in the absence of muscle support is dangerous because it will never heal, or eccentric forces will just mold it down, and there's precarious, absolutely precarious. Anyway, so we kept all eventualities. Unfortunately, the only prosthesis that had augmented base plates is now not available in India. And so that would have been ideal for me to put it in. I prepared for the graft, but I told him that we'll try and go in if I find this fishy, if I find this is infection, because that was in my mind, because he's had 3 intra-articular injections. I said, I'm going to bail out and I'm going to leave it as it is. I will not risk this. But we went in and we just got tons and tons of fluid coming out. But what was interesting is that, look at this. We did a reverse there with great difficulty here. But can you see this? This is his entire infraspinatus in the shape. This is his remnant supraspinatus. And this here is the entire subscap. So the entire muscle bulk was converted to fat. It was there, molded in that shape. I just picked it up and threw it out. And this is crazy, diabolical. I've never seen anything like this. So I can't explain this. And so seriously, there was literally no soft tissue support. Deltoid was good. It was good. So I had confidence to go in, and we've tensioned it reasonably well. It is stable. It has a 0 shock. We sent all this material down to biopsy, and everything came out negative. There's no question of infection. It was just fibrofatty replacement of all these tissues. So it really intrigues me, and I'm wondering that this is such an advanced case that has deteriorated so rapidly. But there's a lot of stress here because the amount of bone loss here, if you can see, is profound. So what I did was I planned for okay, I get the message. Yeah. So I did a run and ream, and I did a reasonable run. I have not flattened him out completely. I have just flattened out the middle section, and he's a little bit in anteversion there, but he's on native bone. So I'm not worried about a bony interface. We're not looking to normalize everything. And we've got a very good hold in the remnant glenoid and good stability. His pain is gone. His shape of the shoulder has come back. The prognosis is still guarded. Even if he gets 90 degrees plus, he's reasonably okay. But that's our plan. Let's hope that it works in position. If there are no other queries from anybody, then I would like Harpal to summarize for us on our behalf.
So, my summary would be, when we have an elderly patient who complains of rotator cuff problem, we evaluate the patient, and in this patient, the diagnosis was clear. There was rotator cuff tear, as Dr. Ashish has pointed out. And the best way to intervene in these patients is, if this warrants surgery, it is better done as early as possible before the muscle undergoes degeneration. The second point here that brings out in this patient is, if you get a dislocation or a subluxation after the rotator cuff tear, we must evaluate the patient properly with all the modalities available to us, a detailed clinical examination, taking help from our radiology colleagues. As Dr. Ashish pointed out, the posterior deltoid was firing, and one of the panelists suggested that we should have got an NCV done. If you're not so confident, then I think it's better to be safe than sorry. Get a NCV done. And if there's no neurological cause, you should warn the patient before you proceed for any kind of surgical intervention, because if you do not explain it properly, as was talked in the previous session, litigations are going high and we would be blamed for the wrong surgical technique. Then comes, once you have done, you have assessed and you want to go ahead with the reverse shoulder in these patients, do a CT scan, evaluate the bony pathologies properly, especially on the glenoid side, do a proper pre-op planning. It's better to plan and succeed rather than not plan and fail, and then go ahead with your surgical tactic and do a good, nice reverse shoulder. Anything anybody would like to add to this?
The 3D CT scan along with the MRI subtracted was very important.
I said CT scan before the surgery.
Correct. Yeah. Excellent. Thank you, Harpal. That's very well summarized. We have just 2 minutes to go. I'll just quickly run through this case rather than discuss it. This is an elderly lady, 73 years old. We'd done a reverse shoulder on the right shoulder, long back, and she'd done that. She's 7 years past that, still well maintained. And now she's decompensated on the left side, which in the past I'd refused to operate. And she was also reluctant. But by the time she came to us 7 years after her right reverse shoulder replacement, you will see that she has this similar subluxation under the coracoid, head has dissolved, C-spine X-ray reasonably okay, MRI. So she's been worked up and she begged me for surgery. And I was absolutely reluctant because this is the state that she is in. But she was so severely disabled. Her daughter's a dentist. She came up and these are the CT workup. There's just half the glenoid available there. There is no, we did an EMG, we did a neuro workup. Everything is negative. So we again use the same caveat that we'll go in. If there's enough bone stock, then we'll go in and replace her. And if not, we'll just leave her be alone. No harm done. So in these cases, I don't resect the head of the humerus before. I go and have a look at the glenoid, check if it's fixable, and then we decide. I've used a wedge-shaped graft like Raman alluded for the last case, and it's almost 13 mm on one side and 8 mm on the other side. And we've used a reverse revision glenoid here component for her. And we've actually managed a decent hold with almost 5 screws in addition to the central peg. So that's sitting in. She's a 2-year follow-up now, and she's pain-free, reasonably okay. These are challenging cases. I wanted to discuss this, but since we're short of time, I thought we'll just discuss. This is a video after 3 months. For the first time, she managed a smile and she's managed a reasonable range of movement. So again, just a rescue salvage surgery. Again, this is, I think, either fools or people with bravado would do this, but she's been our old patient and she really, really implored us to do this. But I have had 2 other patients like these. I've gone in, checked, found that the glenoid osteoporotic, and I've come out not doing any reverse shoulder. So it's not mandatory that we ought to repair. In this lady, after a year, we got her CT scan done just to know whether we are in correct position or not. And the entire process is sitting very nicely with the bone graft, which has integrated very well. So thankfully for us, the wedge graft has integrated, the stem has integrated, the orientation is good, the version is also 0. So it's been one of the more difficult cases that we have done. We've also validated it on the CT with the measurements. And so in conclusion, I think what I wanted to take across to everybody here was, number one, the lock plate has made things very easy. And so there are too many lock plates being done. The proximal humerus remains as a challenging operation. Even today, huge number of complications with proximal humerus fracture fixations. I think we summarized the talk very nicely by Nagaraj, that those are the features. It's important to do CT scans and ensure that the lock plate is not a panacea. A good surgical technique is the important thing for proximal humerus. Anybody who can reconstruct the GT and LT, even in a proximal humerus or a hemiarthroplasty, will have managed everything, because the results are due to a good GT-LT reconstruction, not by putting a plate or a stem inside the shaft humerus. And in the right cases, the reverse shoulder can be a reliable operation. Finally, in conclusion, just wanted to offer that although surgery offers the best chance for a good outcome, the worst complications do result from unsuccessful surgery. I thank Deepak Dave and his team for this opportunity. And I'm also grateful to all my panelists, including Kalpesh, Raman, Karthik, Nagaraj, and Harpal, of course.
Yeah,
thank you very much.
Thank you, Ashish. I think it was a wonderful case presentation, excellent information, and all the panelists, Dr. Kalpesh, Dr. Raman, Dr. Nagaraj, Harpal Singh, and Dr. Karthik. Thank you very much on behalf of the GOSICON Scientific Committee. Same time, we thank OrthoTV also, our local organizers, and the academic partner supporters, Zydus Biovision and Cadila Magnawave. We meet you tomorrow for the trauma session at 6:30. Once again, I thank all the panelists, especially Ashish, for taking trouble or preparing all these cases, and excellent input from all the faculties. So on behalf of the GOSI team, we thank all of you, our academic partners, OrthoTV, and our local broadcasters. Thank you very much. Good night too.
Good night.
Thank
Good
you.
night.
Good night. Good night.
Good night.